All right. Hi, everybody. I think people are coming in. I'm going to give folks a minute or two to log in. While we wait for everybody to log in, I just want to quickly say welcome. My name's Amanda. I'll be your host and moderator. We'll give folks 2 more minutes to get situated in our audience. And if you would like to put your name and where you're tuning in from in the chat, just so we can see where everybody is coming from, we'd love to hear where you're from. I know I'm tuning in from Boston. It has been super cold here, lots of snow. Oh, hey Nina from UK. I know we just chatted earlier this week. Belgium, hello. California, North Carolina, and Alabama. Hopefully it's warmer and sunnier where you are. Excellent. Great. New York City and Georgia. I lived in Atlanta, Georgia for a few years. I do miss it on days when it is negative degrees up here for sure. Excellent. Great. More from Atlanta, Southern California. We'll give folks just 1 more minute to get in here. Although I did hear Georgia had a cold snap too recently, so maybe it is more similar to my weather up in Boston than I thought. All right, in New Jersey, New York. Cool. Awesome. Well, welcome everybody. We will, oh, Columbus, Ohio. I was just in Ohio recently. We will get started now with our summit. So welcome everyone. Good afternoon. My name is Amanda Profit. I am the Vice Chair and Director of Education here at SOLACE Foundation, and I will be your host and moderator. I am really thrilled to welcome you. This is our second annual summit, and our theme this year is Hidden Wounds, Breaking the Silence on Maternal Mental Health. Whether you're joining from home, office, or somewhere in between, we are really grateful that you have joined us. We hope that this is an inspiring and informative event, and we have a great lineup of speakers here with us today. Let me get my screen sharing so you can see all these great resources that we have for you. Okay. Here's our brief agenda so you know what's coming up. This summit is more than just a quick discussion on women's health. It is about empowering you with knowledge and facts, removing stigma and shame from OASI and mental health conversations, and fostering a supportive community. Our goal today is to bridge the gap between medical research and personal health experiences so that we can give you a holistic view of mental health in the obstetric anal sphincter injury space. So you may hear us say OASI a lot, and that is what we are referring to here. The summit is especially exciting for us this week as Solace, MASIC, Birth Trauma Australia, and other wonderful organizations around the world recognize OASI Awareness Week. Be sure to follow these organizations on social media for more informative and engaging posts all week long. We do want to thank our co-sponsors for this event, the University of Alabama at Birmingham Center of Excellence in Maternal and Child Health Education, Science and Practice, and the Alabama Area Health Education Center statewide program have graciously co-sponsored our event. The UAB Center of Excellence in Maternal and Child Health is housed within the Department of Health Policy and Organization, It is one of only 13 centers of excellence nationwide, funded by the Health Resources and Services Administration's Maternal and Child Health Bureau. Its mission is to strengthen and expand the maternal and child health workforce by supporting current professionals and cultivating the next generation of leaders. Alabama Statewide Area Health Education Centers, or AHEC, is comprised of 5 AHEC centers serving all 67 counties of the state. The mission of the AHEC program is to recruit, train, and retain the Alabama healthcare workforce while broadening the distribution of the health workforce, enhancing the quality of care, and improving health delivery to rural and underserved populations in Alabama. You can learn more at their website. What many of us are interested in are CECs. So a little information for those of you here to get some continuing education credits. The Alabama Statewide Area Health Education Center is an approved provider of continuing hours for nurses by the Alabama Board of Nursing. They have awarded this summit 3.1 contact hours. And the National Commission for Health Education Credentialing has also awarded this summit 3 continuing education credits for those holding a certified health education specialist license. To receive credit for attending the summit today, you must do the following. You have registered for the training and you've done that because you're here. You need to watch the entire program, complete the evaluation following the program. When Zoom closes, there will be a pop-up automatically for you. And then upon completion of the evaluation, you'll be redirected to an additional form to request your continuing education credits. You need to complete that within 2 weeks of this program. For nurses in Alabama, the CEUs will be awarded by AHEC. For any other nurses, you need to complete the CEC request form and ask for a certificate of participation. We're happy to send that to you over email, and you can use that to submit to the nursing board in your state. For CHES participants, we will automatically report the credits issued to the NCHEC office within 60 days of the event. So part of the CEC request form asks for your CHES ID number. Some quick logistics. This webinar is being recorded, and we have a contact here for you if you have any issues. We do have an incredible lineup of speakers today to share about OASI and mental health. We will also hear from one courageous woman sharing her story with us. Today would not be possible without you, our audience. Your engagement, your questions, and your experiences are what's going to make this summit a very valuable and robust learning experience. So we do ask you to participate in the conversation and ask questions. Take full advantage of the knowledge and community here. Each of our speaker sessions will be followed by a brief question and answer session. You can submit your questions to the Q&A box. I know there is a chat, but just to keep track of all of the questions we receive, we ask that you use the Q&A feature instead of the chat for questions. While the necessary nature of this event can be considered unfortunate, I am ultimately filled with a lot of pride and joy that we can offer this space to learn more about OASI. SOLACE began due to a lack of knowledge and resources regarding OASI, and this event signifies some real progress in this important arena. Before we dive in, we do want to acknowledge that we have a diverse audience of people here today. Some have suffered OASI, some have suffered with mental health challenges, or know somebody who has. So as a reminder, the information and stories you hear today could be triggering. We will talk about obstetric anal sphincter injuries, birth injuries, and mental health challenges such as suicide and suicide ideation. We recognize this can be triggering, so please prioritize your well-being and take breaks as needed, even outside of our scheduled break that we will have. I would like to briefly turn it over to our wonderful founder and executive director, Caroline Stadler, to welcome you.
Hi, everyone. Thank you so much for joining us today. We're so honored to offer another SOLACE Foundation Summit this year, and I'm incredibly proud that our organization is able to offer this space to connect, learn, and support. When we were coming up with a theme for this year's summit, we were guided by both community feedback from surveys that we had put out and by lived experience as well. For me personally, this topic is very close to my heart. After I experienced an obstetric anal sphincter injury, or OAC, which is commonly referred to as a third or fourth degree tear, I struggled significantly with my mental health. And during that time, I faced deep emotional pain and even periods of suicidal ideation. So I'm profoundly grateful for my great support system that helped me through this incredibly difficult chapter, which includes my husband, family, friends, counselor, and many medical providers who showed care and compassion along the way. With the help that I received, my hope was gradually restored. And this experience just really shaped my commitment to ensuring that no woman who sustains an OAC has to feel like she has to navigate alone. And that commitment is what led me to start the Solace Foundation. I'm also deeply thankful for our strong, passionate board of directors, as well as our dedicated interns and volunteers. With their hard work and belief in our mission, really makes it possible for us to continue our work and host events like today's summit. Our hope is that today helps women who've experienced OAC feel less alone and that it reminds them that there's no shame in struggling with mental health after birth related trauma. And we also want you to feel empowered and to seek support and to know clearly and compassionately that what happened was not your fault. We also hope that the summit helps loved ones and healthcare providers better understand the experience of women with OAC and how they can offer meaningful support. At the conclusion of today's presentation, we'll share a link to some mental health resources, as well as information on how to join our support groups. Thank you again for being here today and showing up for this important conversation.
Thanks, Caroline. If you did not know, we have formally recognized this week as OASI Awareness Week. Various organizations that I mentioned previously around the globe are also recognizing this week as OASI Awareness Week for the second annual year. And throughout this week, we recognize the importance of education, prevention, and support for healing these injuries. You can read this newsletter on our LinkedIn or other social media accounts. In addition, we have a great schedule of engaging content for the week. We have OASI surveys, which are live until the end of the week on Friday. So if you have experienced OASI and you have not completed these 6 short surveys yet, we do invite you to do so. The links for these surveys are on our Instagram link tree. We had a live Q&A yesterday with Brittany Sanchez, our Director of Advocacy at SOLACE. It is now posted to our social media accounts, so you can watch this short 20-minute interview and learn about how all of us can engage in different forms of advocacy in this arena. You can comment or message us with any questions you might have about it. Tomorrow, we will be elevating another woman's story in our Women's Story series, Ezra, on our social media accounts and website. And throughout the week, and especially Friday, we will continue to share news, statistics, and updates from similar organizations around the world on social media. So please be sure to follow along. As briefly mentioned by Caroline, Solace has been conducting a series of surveys over the last 6 months. Topics included things like future family planning, prenatal care, labor and delivery, the 4th trimester, and life after the 4th trimester. The survey that we are elevating today is regarding mental health and trauma. To date, we've had over 100 individuals respond across the United States who have experienced a 3rd or 4th degree tear. And at a glance, we noticed something that many of us have experienced personally, but never really had the ability to quantify, which is that OASI and mental health are very closely intertwined. As you can see from our surveys, which are not published yet, 53% of women reported that they were diagnosed with at least one postpartum mood disorder. 73% of women surveyed reported that they felt their birth was traumatic. And almost 30% of women surveyed reported thoughts of suicide due to their severe birth tear. Dr. Powell is our first speaker today, and he will talk a little bit more about these numbers in his talk titled Obstetric Anal Sphincter Injury. epidemiology, evidence, and emotional impact. Dr. Powell is a urogynecologist and specializes in pelvic floor disorders and reconstructive surgery. He is located in Birmingham, Alabama. Welcome, Dr. Powell.
Hey everybody, thanks so much, and thanks for that introduction. I'll try to get organized here, and I'd be happy for anybody to let me know if there are any issues hearing me. Hopefully, we are all good there. So I'm going to go through some slides. I feel very privileged to get to be here. As Amanda said, I am a urogynecologist at the University of Alabama in Birmingham. I'm on the board of the SOLACE Foundation, and I'm really lucky to get to work with such a passionate group of people. My goal for this presentation and for our time together really is just to briefly review some of the academic literature on obstetric anal sphincter injury and to highlight the importance of connecting that sort of academic, clinical, medical experience with the individual experience of those who've been affected by OASI. This will be sort of my perspective as a clinician, but also somebody who's motivated by advocacy and by my interactions with people who I've seen deal with these difficult outcomes. And ultimately, what I want to see is that I just have that I'm able to just advocate for those who've been through something tough. Let's see. I'm gonna change my settings here so I can see a little better on our slides. And then I wanted to make sure that everybody knew that I don't have any financial or other conflict of interest disclosures to discuss. And with that, we'll get started with sort of a roadmap for what we're going to talk about together. We'll start with a little bit of epidemiology and current evidence. And I think most importantly, we're going to discuss some real gaps in knowledge, which Amanda already referred to a little bit. And I'll conclude with some broad goals that I have as somebody who wants to be a strong advocate in the clinical sphere for individuals who've been affected by severe obstetric lacerations. So just last week, as you can see this reference on the slide, just last week, the Green Journal, which is the main academic journal for all of obstetrics and gynecology, they released a review article in their clinical expert series. Clinical expert series really always highlights topics and key issues that the national community of providers and clinical leaders recognize as being important. So I hope that us sitting here having this conversation and knowing that this is a topic that's important at the national and international level and that is gaining increasing traction for its importance. I hope that makes this group of people feel heard and know that the advocacy that is ongoing from not just this group but others is really having an effect. With that said, I know I don't need to explain the importance of OASI to this group. All obstetric lacerations are important and have implications for an individual's birth experience, but there's no question that the most difficult short and long-term outcomes are those most closely associated with our third and fourth degree injuries because specifically of their effect on the anal sphincter complex. Those are specifically the third and fourth degree tears, as I've highlighted with these anatomic pictures here, that affect the external sphincter in the case of 3A and 3B tears, and or both sphincters and the rectal mucosa in the case of fourth degree lacerations. So this is important from a functional perspective because we're talking about continence, but it also has implications for sexual function, recovery during delivery, et cetera, and we'll talk about a little bit about all of that because it's not just the long-term outcomes we're interested in, it's also that immediate experience, and the postpartum recovery. So when we think about lacerations in general, not just OASI, somewhere almost up to 80% of individuals will have some type of laceration during a vaginal delivery. Our OASI obviously represent a smaller, more severe subset. And thankfully, OASI rates do seem to be decreasing in countries with access to high quality obstetric care. I've highlighted two time frames that we can hone in on in the U.S. and Norway. There was a nice study that compared time periods between 1998 and 2010 to between 2016 and 2021 in the United States, and showed a decrease from 4% to 1%. Similarly, in Norway, it was about 5% from 2002 to 2004, and then down to 2% when measured from 2020 to 2022. So the general thought is that this is mainly attributable to lower rates of operative vaginal delivery, decreasing midline episiotomy usage, and increased attention to delivery technique and perineal support during delivery. Unfortunately, even with these improvements, there are many OASI that either go misdiagnosed or unrecognized, and that limits our ability to mitigate the short and long-term negative effects. And there is even some pretty convincing postpartum perineal ultrasound data that indicates that maybe even up to a third of individuals could have an undiagnosed OASI after vaginal delivery. Some of them even had an intact perineum, so in the absence of a laceration, they still have some effect on the musculature of the distal pelvic floor. And disappointingly, even those with an accurate diagnosis and a good repair may still have some effect on the sphincter in the long run that is visible on ultrasound. So when we think about risk factors, this list are some of the well-established risk factors for OASI. It's unfortunate when we look at this list that lots of them are not actually modifiable risk factors, which means we always have to, as much as we want to focus on primary prevention, I think that's a key component of any public health intervention and any intervention when we're thinking about medicine in general. We want prevention to be the key, but we can never ignore what happens after delivery, where probably more of our modifiable interventions are, or more of our modifiable risk factors. So what we really want to do is focus on prevention for sure, but not ignore postpartum interventions so that we can promote best practices to encourage healing and return to full function, both from a physical and mental health standpoint. When we think about preventive measures, the list is much shorter, and the data is a little bit less strong, but there's some good data to support antenatal and intrapartum perineal massage, increasing blood flow and relaxation of perineal musculature that helps it be more resilient during the delivery process. Warm compress, sort of with the same thought process that increasing blood flow, relaxing the musculature makes it more resilient during the delivery process. And then delayed pushing, and this is an interesting one because also actually in the most recent what's the word I'm looking for? In the most recent journal from the Green Journal, they had a longer term evaluation of some delayed pushing data. And I think we're still scratching the surface of how we should actually use this, but there's some indication that not pushing right when someone reaches full cervical dilation might be better in preventing some of our tears. And then very, very clearly, and this is supported by some of the interventions that have been done, particularly in the United Kingdom, perineal support and control of the fetal head during delivery can be huge when it comes to reducing OASI risk, but not just risk, but also severity. So let's talk about some outcomes. The immediate negative outcomes that we all like to avoid are infection and breakdown. And unfortunately, they are quite common. Some of this is older percentages that I'm presenting, but up to a quarter of higher order obstetric lacerations end up with some amount of infection or breakdown. Up to a quarter is a lot, and that's pretty morbid when it comes to the peripartum recovery period and bonding, breastfeeding, bowel and bladder function, as I reference here, that delayed physical recovery because of a complication to a laceration can have really big implications for what happens in the fourth trimester, to say it that way. Another big thing that I know we would all like to see decrease and really ideally be a thing of the past is the need for a repeat surgery in the first 12 months, because that's almost 10% of anal sphincter injuries. And I think that that has a compounding effect when we think about that delayed physical recovery, sexual function, and mental health effects. Thankfully, I think that we're seeing that these percentages, these high ones in the 20-25%, I think we're seeing those decreasing. Anecdotally, I haven't seen them be that high, especially not in the last 5 to 10 years. And I'm hopeful that it really is an effect of increased awareness, better education, more accurate diagnosis, more skilled surgical repair, better usage of the appropriate antibiotic prophylaxis, and then also very close and evidence-based peripartum care that is, when you take all of those interventions as a whole, that it's starting to bring down those rates. And I'm hopeful that as we, continue to advocate for this very critical part of postpartum recovery, that we're going to see data that bears out the outcomes of all the work that's being done in this space. Let's go on to the next slide. Thank you. Let's go. Yeah, so close follow-up and additional resources are needed in the postpartum period to help with that physical recovery. I mentioned some of the peripartum care bundles that have been used, and some of that bundling of care includes adequate pain control in ways that use topical and systemic medications, more education for people on how to take care of themselves in the peripartum period, avoidance of constipation, and screening for urinary retention. These are all things that I think have been sort of left by the wayside in some ways, but are critical to us guiding people through this recovery process. Close follow-up, even within the first 1 to 2 weeks after a delivery, not waiting till a 4 or a 6 week postpartum visit, can really help identify these issues sooner, and interventions can be offered that can hopefully help promote better healing. Now, it remains to be seen whether or not we can prevent or mitigate the long-term continence complications of OASI, and this is definitely an area of active investigation. Fecal continence almost universally improves in the short term, but that sort of remains to be seen what kind of effect we can have in the long term. But where there's a serious gap is what I want to focus on this slide, is it on the effect of OASI on sexual function and mental health. I've put just 2 references here because there really are so few well-designed studies of sexual function and mental health in the postpartum period after an obstetric anal sphincter injury. And it's, I think that these references are really important, but they just have a lot of limitations. And I think that this is where the gap between the individual experience and the narrative medicine approach to taking care of people in this postpartum period can really help take us to the next level of finding out what should we offer, what can we offer, how can we be better advocates for those that are dealing with something difficult like this. So the sexual function literature would tell us that in general, there's a delayed return to intercourse and a higher risk of pain with intercourse after an OASI, especially in the first year or so. The study that Fodstad did that was published in 2016 it's really pretty small. It has a lot of potential confounders, and it's not really generalizable to everyone that we would think of as the population at risk for these tears. But it does confirm some things that we would hypothesize to be true, which are, again, delayed return to intercourse and even pretty high rates of pain with intercourse, even up to a year after a delivery. There's even less data on mental health, and it's generally limited to estimates of postpartum depression. This study from Molyneux is from 2024. And one thing I like that they did is they included some measures of perceived body image, the impact of pelvic floor symptoms on parenting. They also measured symptoms of anxiety, depression, and PTSD. But one study is really insufficient for helping us get a clear picture of what individuals who have gone through this experience, of what they really have had to internalize. And so the results are in line with what we might think, but it's not a particularly large scale or generalizable study, and really just opens the door, hopefully, for a lot more intensive investigation, so we can better describe what this experience is like. We can go on to the next slide. So a big discussion and a difficult discussion for those who have suffered an OASI are what to do with a future delivery. We know that 75% of individuals will go on to have a subsequent pregnancy and delivery, and that recurrent OASI occur in about 7% of subsequent vaginal deliveries. Clearly, any person who sustains an OASI should be able to choose a different mode of delivery, should be able to choose a cesarean delivery if they desire. But it's not entirely clear that this truly decreases the risk of fecal incontinence in the long term. And I think my stance on this is that everyone should be offered this as an option, but that they should never be told that they have to choose it, or that because they choose it, it's going to completely make everything okay in the future. So I just think we have to have some real respect for individual autonomy, and individualize this discussion for everyone. So here again is some of our SOLACE data that Amanda has shared. And I just was really struck by the same numbers that she presented to everyone, and I want to just highlight them again. Because qualitative research about the mental health effects of OASI really are limited. These percentages tell us very clearly that there's some significant mental health effects that I think is the medical community, and probably in the general population at large, that we have underestimated, and that we've had limited resources for. So I just don't think that we should be surprised that our survey respondents have identified that their deliveries were traumatic. I don't think we should be surprised that it is a significant source of postpartum anxiety and depression, or even might lead to thoughts of self-harm. But I do think that we should use it as a call to action. And so to move on to the next slide, I just want to conclude by just talking about some personal goals, and some goals that I think that we should have as those who are advocates for women's health. And really, this is just my personal perspective, but it's that as clinicians, we should always be involved in promoting quality improvement efforts that support evidence-based care, and especially for the critical peripartum period in the fourth trimester. Accurate diagnosis, excellent surgical repair should be non-negotiable for those who have a difficult delivery or a traumatic delivery that involves an OASI. And in addition to that, we really, really need qualitative research that better represents the individual experience of OASI, so that we can increasingly find better resources for postpartum recovery. I really want us to get to a place where trauma-informed care models for all individuals affected by OASI that really emphasize safety, trust, empowerment. I want these to be the norm rather than the exception. I think that giving a voice to and listening to those affected by OASI might tell us as a group that that promoting new models of care, whether that be group postpartum care, or universal pelvic floor physical therapy, or definitely specialized postpartum perineal care clinics, that these are things that can promote the physical recovery for sure, but may also really have a ripple effect that helps our mental health outcomes as well. And so I'm really thankful to get to share in this experience with you all, and I'm hopeful that as a group we can have some really good conversations and continue to advocate for such an important topic. On the next slide are a list of my references that a lot of this information is distilled from. I want to highlight that even though I mentioned over and over again the gaps in knowledge, the lack of mental health data, the need for increased patient-reported outcomes, I don't want to ignore the fact that there are some really passionate people worldwide who I have learned a ton from, and who the medical and clinical community as a whole owes a lot to for doing our very, very best to get the best outcomes for everyone who has a difficult delivery. So thank you so much for the opportunity to speak with everyone, and I hope you enjoy the rest of the summit. I'm going to be happy to
Thank
entertain any
you.
questions if anybody has some.
Yeah, thank you so much, Dr. Powell. I will um, I will start us off with just one question. I know we got one in the chat, but I wanted to ask you, can you tell us a little bit more about what group postpartum care is? What does that look like?
Yeah, so I think it's something that hasn't been done in a lot of settings. Where it actually started was with group prenatal care, and I think some groups have translated it into the postpartum period. And it's as simple as scheduling a cohort of people who were at the same gestational age through their pregnancies, then having them scheduled as a cohort, and sometimes just giving them free space, giving them a physical environment to interact and support each other, and not feel isolated. So I don't know that it's been done. We have not done it here. It's not something that I've seen firsthand, but something that I've heard about that I think is pretty inspiring, mainly because it allows that sense of community and fights the isolation that I think is a big part of some of the mental health outcomes.
Great, thank you. We did get a question. I'm going to kind of generalize it a little bit more. Um, for folks who maybe have had a repeat severe tear, third or fourth degree tear, do we have statistics on future delivery outcomes? Like what is
On
the current status of repeat tears and what we know
Yeah.
about?
So let me try to give a couple clarifying factors. So number one,
Mhm.
it is harder and harder to gather data on that simply because lots of people do choose a cesarean delivery for a subsequent delivery. So, you take a small number of people, then you make that even smaller. So it just takes longer and longer to gather data there. But what I would say is we know that there's that 6.8-ish% risk of a repeat OAC, right? Um, and what we really don't know is, does that second hit, does it for sure lend itself to worse continence outcomes in the long run? I think my instinct is yes. I think that again, having participated in a lot of subsequent repairs, I do think there's no question that when you think about tissue health, um, and tissue viability, when you have an already scarred area of tissue, it makes it harder to get your best outcomes from a repeat tear. And so I do think that it's an area where we don't have truly cut and dry data that's super reliable. But my sense is that it tells us that the subsequent tear is worse than the first often, and that it does, even though we don't see it clearly rising out of the data, I do think it confers an increased risk of difficulty with bowel control in the future.
Okay. Another question from the same entry there is, how might someone know if they need reconstructive surgery? Because like you said, we don't always get diagnosed right then and there with a tear. Sometimes they're missed. Sometimes we find out later that we're having symptoms and because healing isn't happening. So how might we know if we need reconstructive surgery?
I'm so glad you asked this. I came from clinic this morning and I had this exact conversation with someone. And so I think where I have a bias is that I I feel frustrated when I have someone come in who says, well, after my delivery 20 years ago, I was told everything was fine and that I was healed. And but I haven't felt the same since. And while I don't want to throw a bunch of blame on providers who are telling people, hey, you're healed, because I do think a lot of it comes from a good place where people are trying to be encouraging, etc. But I really do think this is symptom driven. And so if someone has um, pain, scar tissue, um, asymmetry, or other symptoms, whatever they may be, and they think something is not right, I think you just have to keep asking the question and maybe even seek subspecialized care. And I don't want people to have to be their own advocates in that scenario all the time, but I do think it's honest to say that sometimes that is the way that it has to be, at least right now. And so to summarize that, I don't want people to just be told that everything is healed when they don't think it is, because how they feel, honestly, in my mind, supersedes what someone's visual exam is. And if there are symptoms, whether it's asymmetry, pain, protrusion, bowel control issues, etc., they deserve to have a conversation about, is there something that we could do to make this symptomatically better? So symptoms should drive everything, not just what someone was told at their, postpartum visit.
Okay, that makes sense. And so for beyond the visual exam, you said, so if someone has OAC and they do not have a health background, they don't really know how to self-advocate, who should they be asking to see? What kind of tests should they be asking to
Yeah,
pursue?
that's an excellent question. I think that starting with an OBGYN is a great place to start. And then not being hesitant if needed to ask for a second opinion or ask for subspecialty referral. And in general, I think that's going to be probably to either a GYN who specializes in GYN surgery or a urogynecologist. I think those are the people who work the most in that space and are most adept at translating symptoms into an action plan. And to be clear, not everyone needs surgical revision, not everyone needs surgery, but they do deserve to have that discussion with someone who would be willing to walk through that with them. And then as far as testing goes, I think at this day and age, perineal or even transanal ultrasound is helpful for some diagnosis, but it's not universally required, and it's not something that someone has to do in order to get more answers. So it is an option, but it's not a requirement. There are also some other things like anorectal manometry, things of that nature, that I think, except in certain circumstances, you don't necessarily need. So I don't think anyone has to be seeking specialized testing so much as potentially just a more experienced provider who works with these types of problems.
Okay, great. That's helpful. Another question, how comprehensive is OAC education for providers during their schooling and training? And maybe you can speak to that as a urogynecologist.
Yeah, I can. I can speak to that very clearly. Also because I am one of the associate residency program directors for our OBGYN residency program here. And what I'll tell you is your mileage may vary. And I hate to give that answer, but it is just true. And ultimately, the training that and OBGYN receives in this space is very dependent on who trains them. And it's not that anyone doesn't have the intention of providing the very highest quality training. Everyone sets out to do that, but whether or not that actually gets translated is probably pretty variable. So I think in my mind, the way we do our very best job of that is number one, we advocate for this as a very important part of our training, and that's so I can speak to our approach here. We advocate for this as a very important part of our training. We use simulation and didactic instruction to make sure that it is always on people's mind during and following a delivery. And then at the very base level, you can't repair an OAC well without first diagnosing it. And so I think that's something that I harp on more than anything is that accurate diagnosis is the most important detail, because if you are not aware that it has happened, you can't adequately repair it. And so that's a long-winded way of saying I hope and I'm confident that everyone sets out to train the next generation of providers extremely well in this space, but there probably are better and worse experiences for those in training.
We have time for a couple more questions. One question is after a tear, if a person was going to pursue another pregnancy but choose a C-section, are there any risk factors for tearing again or more incontinence issues? I mean, obviously we know this may impact the pelvic floor regardless just by carrying, but can you tell us a little bit maybe about that?
Yeah, so I think that is why, I think I mentioned this, there is mixed data on whether or not having a cesarean delivery subsequently actually improves the long-term continence outcomes. And it's just what you said, that carrying a pregnancy alone can't, even with regardless of mode of delivery, can have implications for the pelvic floor. Furthermore, how someone recovers, whether they have an OAC or not, really can, has a strong effect on their long-term outcomes. So that's where I still think that this is a personal autonomy type decision and a very individualized decision. I don't think anybody should feel pressured to choose one way or the other. And I think it's understandable to choose either or, depending on that person's experience. So I'll give an example. If someone had an OAC, but they healed reasonably well, they feel well afterward, and they choose either a cesarean or a vaginal delivery for a subsequent pregnancy, I think that's fine. Where I might guide someone a little differently is if they had an OAC, had an infection or breakdown and required reoperation, or they had a fistula. Those are people who I might more strongly encourage to consider a cesarean delivery, simply because I think those are the people who are at highest risk for the worst long-term continence outcomes, because it's just sort of a repeat damage to an already potentially affected tissue. And so again, I would still never tell someone they had to do that, but it gets really individualized when you start asking these questions. And I think that's why our data is still a little bit mixed, is because that person who had an infection, a breakdown, and a subsequent surgery is a different scenario than somebody who had a bad tear, but all things considered, had a good healing process. Their pelvic floor seems to have recovered, etc. Those are two different people, even though they are both people who had an OAC. They really do fall into different categories.
Right. Yeah. Okay. Thank you so much for answering all these questions. And if you think of more questions, audience members, please feel free to continue to send them in. Our panelists are sticking around, so we can always kind of go back to other topics as we go. You might have an idea spark just by listening to the next talk. However, we are going to take a quick break for 10 minutes, and then we're going to get to our next speaker just so that everybody can get some water, stretch your legs really quick. When we return, we are going to start off our chat with Blair Evanowski. So 10 minutes, please be back here at 3 o'clock Eastern Time.
Thank you.
All right, hopefully everyone is heading back after our quick break. I know I'm drinking a ton of water myself. We are going to jump back in with our next speaker. So today we have Dr. Blair Banoski with us. Blair is a pelvic health physical therapist and owner of Pregnancy and Postpartum Physical Therapy in Westford, Massachusetts. She combines evidence-based education with clinical experience to support women through pregnancy, postpartum, and beyond. Blair is passionate about empowering both patients and providers to feel informed, confident, and supported at every stage of life. Her talk is titled When the Body and Mind Both Hurt, Understanding the Overlap Between Pelvic Floor Dysfunction and Postpartum Mood Disorders.
Thank you, Amanda. I am very excited to be here today and talk all about this. I loved Dr. Powell's talk, so this is great. We'll get started. I want to talk about something that Dr. Powell just started. Many of us have seen, maybe experienced, but we don't always have clear language or framework to talk about the overlap between pelvic floor dysfunction and postpartum mood disorders. It's a continued conversation about bodies, but it's also a conversation about identity, recovery, and trust. So postpartum depression is one of the most common complications after childbirth. It affects roughly 14 to 20% of people after birth. Urinary incontinence is also extremely common in the postpartum period, with about 31% reporting symptoms after birth. What's particularly important is for people who have urinary incontinence, at 12 weeks postpartum, they are 3 times more likely to still experience urinary incontinence 12 years later. I'm going to say that stat one more time. People who have urinary incontinence at 12 weeks postpartum are 3 times more likely to still experience incontinence 12 years later. These issues are not rare, and they're not always short-lived. Recent research has helped clarify that urinary incontinence is not just a quality of life issue, it's also associated with mental health outcomes. A 2024 systematic review published by the American Journal of Obstetrics and Gynecology found that urinary incontinence may increase the risk of postpartum depression by an average of 45%. The relationship is so complex and so multifaceted, but we know it's so strong. Urinary symptoms can change social relationships, limit participation, and contribute to feelings of anger, shame, and low self-esteem. Hormone changes and sleep disturbances may influence both the pelvic floor symptoms and the mood. And in both conditions, early intervention is associated with much better outcomes. We also know that physical activity and movement really matters. The Journal of Affective Disorders found that women who performed at least 150 minutes of moderate to higher intensity exercise during pregnancy and postpartum had substantially lower risk of postpartum depressive symptoms. That's less than 22 minutes a day. There are some other research studies to say that a lower intensity, same number of minutes, 150, also helps. So I think that study is so helpful in proving that lesser exercise can be really, really helpful. And instead of like kind of scaring everyone away from exercise when there's been an injury, knowing that if we can find something that they're able to do, it will actually help. It reinforces that physical and mental health are not separate silos. They're so deeply intertwined. So what is the research missing? As Dr. Powell already pointed out, a ton. It's missing so much. I just told you about urinary incontinence, and I couldn't even add bowel incontinence because there's just so little research. And so what I see in general in pelvic floor research is they're using urinary incontinence as like this end-all be-all for describing pelvic floor dysfunction. And they see the same thing in postpartum mood disorders. In the research, they're using postpartum depression as the end-all be-all. But we know there's so much more. So we know that some of the other pelvic floor dysfunction that can happen after giving birth, other than the urinary incontinence, is fecal smearing and fecal incontinence, pelvic organ prolapse, pain with vaginal penetration, pain with anal penetration, urinary frequency, intense urge, fecal frequency, constipation. The list can go on and on and on. And then on the same bandwidth, in mental health, there's so many other things besides postpartum depression, postpartum anxiety, postpartum OCD, postpartum psychosis, suicidal ideation. There's so many other things that need to be researched. Really excited to see the new SOLACE survey asking about those things, but we don't have the research there. And when we only study one slice of dysfunction, just that urinary incontinence or just that postpartum depression, we risk only screening for that in practice. And I find that to be very, very true. So most screening research focuses on urinary incontinence and depression. And when that research gets narrowed, the clinical screening follows. So then in clinical setting, most patients who are postpartum are asked about depression. Sometimes they're asked about urinary leakage, but rarely are they asked about bowel control. And bowel symptoms are some of the most difficult symptoms for patients to bring up to their providers on their own. We really need to be asking about it, because if we don't ask, we're probably going to miss it. So stepping even further from the research, what I see and what Dr. Powell also said, what are our patients really worried about it? When we step outside, we often hear something a little bit different than just those symptoms. After a lot of birth injuries, but especially OAC, most of my patients are less focused on any single symptom and are much more worried about their future. Can I handle another pregnancy? Will I ever feel like myself again? Will intimacy ever return to safety or normalcy? The questions are often unspoken, but they shape recovery. And if we can have better conversations and people can speak them, they're going to do better. So, what can we do differently as providers? We can screen beyond normal urinary leakage and depression screening tools, right? Having a real conversation really matters here, because we just don't have great screening tools for all of the things. Sitting down with somebody and actually listening to them is something, unfortunately, that sometimes we don't have in the medical society anymore. But when we can do that, we can get so much more information about what's going on with the person, what they're worried about, what their true fears are, and then really help them with that. We can normalize these experiences early and reduce shame by naming what's common and treatable. Most of my patients who have bowel dysfunction, especially if they have fecal incontinence, think that they're the only one. And I'm like, I saw another one today. Like there's other people who are going through this, and that can feel helpful. It can bring on a little bit less shame or a little bit less discomfort talking about it, at least to the person who's saying, hey, I see this. And third, we can refer earlier. For both physical and mental health support, we really like to see people in much, much sooner than we're traditionally getting people. I think it's still a loss, even within pelvic floor therapy, to realize that most of our clients who gave birth should be seen almost immediately. Some hospitals are starting to get a pelvic floor therapist in. My clinic tries to get people in within 2 weeks. But I still see a lot of people saying, oh, they had a child, you can't see them until they're 6 weeks, when they would be cleared for internal work. And there's so much more that we can be doing. And I know that there's so much more that mental health providers can be doing when we're getting people earlier. So we can move on to the next slide. So to support better healing after OAC, we really need to go back to what are the patients worried about. They are often more worried about their future than any single symptom. And if we're not bringing it back to their major concern, we're not going to help reduce some of their fear and reduce some of their mind wandering to other things. We need to bring this up for them. How can we do that? So patient education is often missed and is one of my favorite things to do with most of my clients, but especially someone recovering from OAC. Patients are worried about the future. If they don't bring it up, I will. Dr. Powell just did a great job describing a lot of things. One of those things is that most people are going to be offered that vaginal birth or cesarean section. And we know that that cesarean section is not preventative of all pelvic floor dysfunction. What I don't see in practice is most people getting a good conversation at their OB in determining which route they're going to go. And then that fear continues to rise. Or they try to have that conversation before they're even pregnant, and they're a little bit pushed away of like, oh, we'll figure that out when we get there. And most people really want to have those conversations because they want to reduce the fear. Reducing that fear can really help a lot of things. I've seen it help physical symptoms, mental symptoms. It really does help to have these conversations. And so the conversation of the C-section isn't super protective, right? We could still see dysfunction is helpful. Dr. Powell had this in one of his slides as a risk factor of the initial tear being larger is the physical therapist or doctor could measure the perineal body. So the space between the vaginal opening and the anal opening. If that's smaller than 3.5 centimeters, we know it greatly increases the risk of an OASI from the get-go. And so if somebody does have that, you can use that information with them to say, okay, you were at risk prior to this birth, most likely you are now because of the spacing here. Some people really like that evidence, that like number, that data. Those people who love that data might want, as Dr. Powell had suggested, an ultrasound to check if there's a defect in the external anal sphincter. A lot of times research talks about pelvic floor reserve. It's not saying that the person would not have another injury. It's just saying what can the person's tissue tolerate. So pelvic floor reserve is the level above the minimum that your body needs to function to be able to maintain continence. Most people have an enormous pelvic floor reserve, especially the posterior pelvic floor around the external anal sphincter. But we start to see it diminish over time in women. And so what Dr. Powell is leading with is like, sometimes their symptoms aren't there now, but in 5 to 10 years, they could be because the pelvic floor reserve might not be enough to deal with aging because we've reduced some of it with birth. And so we talk through, what does that look like? What might your functioning be, right? If you have an ultrasound, if you get a pressure test, that mammometry, what's your resting pressure and can you increase your pressure? And we can see how much pelvic floor reserve, and we can't see, unfortunately, we can guess how much pelvic floor reserve that person might be, and they might be able to make a better decision around that because some people love stats, numbers, and data. There's also people who don't, and you talk more about like, okay, you did or didn't have an infection, you did or didn't have a fistula, you didn't or didn't have a second surgery. What is your scar tissue like? Is it that real dense, immobile tissue that is going to be more difficult to give you that like usage that we would need for that pelvic floor reserve? And so it really is dependent on that patient, how we're describing what that future pregnancy might look like and what birth might look like. And I do firmly believe when the patient feels really empowered to make a really good decision for them, no matter the actual outcome that we're seeing and we're writing on paper, they feel less trauma because they felt very empowered to make that good decision for themselves. And they didn't feel forced into a decision like you're definitely having a C-section because you had an OAC before. So try to have that good conversation with them. Pelvic floor therapy is very successful in treating symptoms of OAC. Pelvic floor therapy can be very helpful in talking through some of these concerns. We're usually very good referrals to make sure that they're getting seen mental health. We usually have another patient we can talk about, like this person, this is what they went through, this person, this is what they went through. It can be very, very helpful. But that pelvic floor reserve will ultimately decide whether someone stays continent throughout their lifespan or not. So getting to start that conversation early can be helpful, seeing if they need, lots more hip strength, something else, because we're going to see some pelvic floor reserve possibly problematic in the future. Pelvic floor therapy should be the standard of care, but I think we all know that pelvic floor therapy is understaffed and often an out-of-network service. And so not everyone is going to be able to get pelvic floor therapy. And well, I think that's really hard and not great. And I hope that we do see that change in the future. Right now, we have to deal with that as a reality. And so I really like to remind people that while a therapist may be really good at helping you decide what exercise to pick, we know that exercise is helpful. And it's so easy to say this person has an injury, they're not able to receive therapy for it, we're going to rest. We really do want to see that person start a gradual return to exercise. What exercise that is matters a lot less than the fact that they're doing it. They're feeling safe with it. They're not increasing their symptoms with it. And hopefully they're getting up to that around 150 minutes a week of exercise. But we're going to applaud and cheer for anything they get, whether that's slow walking, whether that's fast walking, whether that's up a hill, whether that's yoga, whether that's Pilates, whether it's weight training. There's not something that's absolutely unsafe because of an OASI tear. And most of the time, people are pretty aware of what feels good and what doesn't. And for most people, the benefit of exercise is going to outweigh the risk. And so, encouraging that gentle exercise, even without a pelvic floor therapist, is probably a good idea for most people. And yet, what I tend to see is people just resting and resting and resting, or saying, like, oh, I can't because of my injury. And of course, they're then still picking up their kid and playing on the ground and doing all these other things. Like, there was and is some ability for some exercise for most people, and probably the risks would outweigh, or the benefits would outweigh the risks. Sorry about that. Good. So I have fun facts on bladder health. We should pee every 2 to 4 hours during the day and 0 to 1 time overnight. Drinking less water will often make you more likely to have urinary urge or incontinence, not less. You should not have to push to pee. Constipation can be the main cause of urinary incontinence, and Kegel exercises aren't the best course of treatment for most clients. I think my references are on that slide, and my last slide, keeping the conversation going. I'm really glad everyone is here today to take part in this conversation. My hope is that it encourages earlier screening and broader questions with that screening, and a more integrated care for postpartum patients, especially those recovering from birth injuries. Remember, patients need to be asked about their symptoms, but are often more worried about their future. I'd love to continue this conversation further. If anyone has any questions, or if you want to keep in touch with me, here's my ways to find me.
Thank you so much. There are things that I learned just by listening to that, and I've been like in this world quite a bit. So that was super great. Lots of good questions coming in for you, and keep them coming, everybody. Put them in the Q&A. Let's start with, is it ever too late to reap the benefits of pelvic floor physical therapy after a tear? Right? You and Dr. Powell both mentioned like some of these issues can show up 20 years later.
Funny, I have 2 stars on my thing that I did not read or get to, and one of them is it too late? Because everyone keeps talking, especially me, about earlier and earlier and earlier. And then I wanted to touch on pelvic floor therapist training, as someone had asked Dr. Powell. It is never too late. We do see a slight ease in care when we get somebody a little bit sooner. We do see, I had a mental health provider chatting with me, that combo of getting people in around that 2-week, the mental health and physical component probably changes quicker when we see people early. But it is never too late. I have somebody who's 15 years post. I sent back to a Urogyne to be like, shouldn't we with surgery? She ended up not going the surgical route, although she was a candidate, and we were able to make drastic differences. And that's why she didn't go on with the surgery. I truly believe her having an opinion, her going to see the surgeon, getting a good understanding that she was a candidate, she could do that. I truly believe that mattered, even though she didn't opt to have surgery. Reducing some of the or giving somebody some choices and some say in the matter, I really think that really helps people. And I think it really helped her in her physical therapy journey, being able to be so successful.
Great.
And we see a lot of people when they hit like perimenopause, menopause, because that pelvic floor reserve goes down. And so they were like, okay, even though they had a significant tear, and then that lack of estrogen, lots of other things happening. They see their symptoms then, because that pelvic floor reserve is going to go down as we age. So we do see people then, and they are able to see some benefit. Absolutely.
Great. That actually brings us to another question, actually. So speaking of pelvic reserve and menopause, how could somebody, like, what should we be asking for if we want to get an accurate picture of what our reserve looks like post-tear or even during menopause? How can we know?
We don't know, mainly, like the research is not there. So that perennial body length, 3.5 centimeters, that's the space between, like, right at the end of the pelvis, right at the end of the vaginal opening until the beginning of the anal opening. 3.5 centimeters or greater is what we're hoping for there for pelvic floor reserve. That's not great. We don't have good research, right? So we're not working off of like, well, this person, when they were 18, this is the number they had. And so how much should that change or can that change? We don't have that information. So people who naturally have a smaller space between the perennial space of the perennial body, that space between, we don't know that that should or shouldn't change the same amount as somebody else's. So it's not great, right? The research there is not great, but that's basically what we're looking at from a pelvic floor therapy standpoint, is like, what is that spacing? And then is there anything we can do for that? We do see sometimes tightness really make that perennial body small, and then we can work on lengthening and we can actually see an increase. Other people, it's really small and we're working on lengthening, doing all these things, and we don't see a change. And so while we're trying, as Dr. Powell said, like we can't tell yet who is going to be okay and who's not. We have things we're looking at. So the main thing I'm looking at in my clinic is that number. My really data-driven folks, I'm looking for an ultrasound of the external anal sphincter, and we're looking at if there's more than a 30 degrees of defect. And if they do, we're worried about their pelvic floor reserve. And then they can do a pressure test, mammometry, where there's like a catheter put up the external anal sphincter. It's like thermometer size. And it checks for generalized pressure. There should be pressure in the rectum always. And so we're looking for a number about 40 or higher of pressure, of millimeters of mercury. And if that pressure is there, that's good resting tone, we think. We don't know for sure. And then if you try to squeeze purposefully, can you change that by 20 millimeters of mercury? And if you can, that's good pelvic floor reserve, we think, again. But do we have great norms on this? No. But that data can help some of my real data-driven people to make some decisions or to think about their future. Maybe they're making a C-section versus vaginal birth. Maybe they're making a hormone replacement or not hormone replacement. Maybe they're making another surgical decision. Some people love data to decide, and we don't have great data, but we do have some stuff that we can pull in and say, well, what we think is, is another tear going to cause more symptoms? I think that is more on what is your pelvic floor reserve and less on what exactly happened with your second tear, I think, but we don't know. And that is what's so frustrating, is like kind of standing on an island and being like, I hope it makes sense. But we don't have great data. And I really think that not having that data of even norms is tough. Tough.
Right. We are getting lots of great questions, and some of them kind of go together here. So one of the questions, you mentioned lengthening. Now, often we are told that Kegels are great, and you mentioned they're not the end all be all. So, give us more information about why Kegels are often not the best when it comes to incontinence.
Yeah. So especially after an injury, OASI or other, muscles tend to guard. I use this analogy that I hate, and if someone came up with a better one, I would love it, of a neck in a car accident. And so when your neck goes through too much range of motion in the car accident, we tend to end up really stiff and really tight, right? And so during birth, when our muscles and our connective tissue goes through too much stretch, we also see people end up very tight. It's a reactionary like guarding that muscles will do because of injury, trauma, anything. And so we wouldn't be giving them a bunch of shrugs to try to make them better. The same thing can be true for the pelvic floor. A lot of people just in general have a sense of the ability to turn on, and they don't have a great sense of turning off and lengthening. that can just be person to person. And then what happens after birth can be both. You find people who their muscles are like, I'm going to take a little vacation and maybe some strength would be really helpful for me. And then you find a lot of people in this guarded, real heightened sense of trying to support everything, right? Maybe an organ is sitting a little bit lower than it used to. This tear is there and it hurts. My abdominal wall is not doing as much work as it used to because it got really lengthened, and muscles work on a length tension relationship. And so that's not doing as much as it could. And so maybe I will squeeze really hard instead of staying at optimal length and being able to be used nicely. And so we really have to go check what the muscles decided to do based on your whole life, but also based on that one experience of birth, and then treat what is there. This is what makes it so hard about pelvic floor therapy not being, just in everybody's ability to go to. Is I would love if I was like, here's a great program for most of you, but it's not. Unfortunately, it's not. Those muscles just do a lot of different things. With OASI, we sometimes see one side of the pelvic floor muscle being like pulled off or injured, or that nerve not connecting well. And when there's one side versus the other, we need to do something different. And it's just so difficult to say, like, here's a great protocol of what should happen for everyone. And brings me to the other point that I wanted to make about what Dr. Powell said, like, how's the education? It's okay. It's good sometimes, it's bad sometimes. Pelvic floor therapy, there's zero in PT school, or zero when I graduated in 2009. There's a tiny bit now. But most of us went to extensive post-ed care to learn pelvic floor therapy. And then what did we decide to specialize in? I will say there's this like interesting rhetoric out there that maybe the pregnant and postpartum patients are the easy ones. So sometimes they're put on caseloads for somebody who hasn't taken maybe as many courses. And I get annoyed by that. There's so many things, like, sure, if a person had a vaginal birth with no tearing, then maybe. But everyone brings all of their stuff from their whole life. And so no pelvic floor therapy patient is easy to me, but especially OASI tears. I didn't have knowledge of the perineal body or the ultrasound or mammography, or even like categorizing the levator ani, it's part of the pelvic floor muscle, whether that may or may not have been avulsed, torn, injured, the nerve's not doing well. I didn't have a lot of that knowledge for years as like a pretty decent, in my opinion, pelvic floor therapist. So there's a wide variety out there. And I do think sometimes it takes a visit to a second therapist to get all of the things you could get from one.
Okay, we have time for a few more questions, and I do see other questions that we will have time to get to towards the end of our summit today. But can you tell us about, this is a twofold question. Does engaging in pelvic floor therapy and regular exercise prior to pregnancy play any kind of preventative role? And is there any way we can ensure more women know about this before they give birth?
Yeah. Again, we don't know. There's a little bit of research about perineal stretching, that maybe it reduces your tear by 1 degree. There's also some research that says no on that. There is a lot of talk and hope and light research. Dr. Powell suggested that when we push or how we push might change our outcome. We see that a lot. Pelvic floor therapists really believe that, as I think a lot of other medical providers in birth do. What's really hard about that is preventative care, and preventative care is not covered in physical therapy. I believe in occupational therapy either. PTs and OTs can do pelvic floor therapy work. And so most providers who are doing that kind of care are PT, OT, pelvic floor therapists, maybe a doula or midwife. And it's not going to be covered by insurance if it's with a therapist because it's preventative care. So that is hard. It reduces, again, who's getting this. So my clinic, which is out of network, we're going to check perineal body length, and we're going to work more on breathing and positioning on somebody that we think might be more at risk. We're going to work more on that tissue change. The research on that is like stretching the perineal body the amount that needs to stretch is insane during birth. My experience and thoughts and beliefs on that is if we can teach your body that is a safe spot to stretch, that does stretch, that the tissue will be more resilient during birth. I think Dr. Powell said something very similar, that tissue reaction during birth matters. And if it's really scar tissued, it's going to have a tougher time reacting and being resilient during birth. But some people just have more difficulty. So again, if that person is not presenting with pain, we're now doing conservative care by stretching that. So most therapists are very good at being like, that does hurt, right? That does hurt. That hurts. That hurts, so that it's not preventative care. But it does fall into preventative care. And then it's hard to get people trained, and it's difficult. I wish there was more research, and I wish that it was more definite that this is how things work. That pushing at 10 centimeters dilated might not be best, because some people might need to go a little bit further because sometimes the baby's not fully engaged. And could we get the feeling of when the mom thinks that they should push, or the pushing person thinks that they should push, when that happens, can we then push? Needs a little bit more research, but it seems to be helpful. So I think you can do things. We do some baby positioning exercises. The better position the baby could be in, the better birth outcomes we see. That's researched. Can we affect where the baby sits? We think that's not well researched. I always say, though, babies know best. And if you did all of your work and they're in a weird position, it's because they knew. They're way smarter than us. So don't take guilt on with that. But there are things you can do. But I will tell you, I own a practice called Pregnancy and Postpartum PT. We see people a lot for wellness. They're doing great. They just really want to have a good birth. And most of our clients do. But I do have a woman on my schedule who I saw throughout her pregnancy who did sustain a 4th-degree tear. And so sometimes you can do all the good in the world and these results happen. I always wonder in my head, had she not done all of this work, would she have ended up in a C-section? Would that have been better? Would that have been like, the what ifs are too much in my brain. I can't imagine, right, then patients, all of their what ifs. But there is work to be done. I do wish more of it was done during pregnancy. And also it can't clear everyone of having a non-ideal outcome.
And last question for now, and we will circle back to some of these. I know you were just saying that the research is mixed, but for folks that are planning to do a C-section even, we talked about a little bit with Dr. Powell that even the weight of carrying can impact your pelvic floor. It can worsen prolapse, maybe. It can increase incontinence. Is there any kind of strategies you have about controlling pressure or bracing yourself to maybe negate or be able to reverse those after birth?
Yes. Yeah. There's so many, right? And we're going to look at what that person brought with them. But the major things I see is pressure increases when our midsection doesn't move well. It puts a lot of pressure down, which is either going to go into the abdominal wall or the pelvic floor. And so when you get pregnant, you start growing a belly, your rib cage and your hips get stuck together, right? If you're rotating like this. We're losing this ability for the rib cage to rotate separately from the hips. And then the diaphragm, one of the coolest muscles in the body, in my opinion, actually moves up some to make all this space for the baby, your own baby. And that is going to restrict all of this a lot. When we're really restricted here, it's like squeezing on a toothpaste tube. The pressure is going to go somewhere else, and it's going to go into the abdominal wall or the pelvic floor, most likely, or your back if you've had something go on there. And so a lot of times my generalized, how can we help kind of everyone that's not going to be hurtful for pretty much anybody is trying to get here to rotate separately from here. I love the exercise called an open book. You bend your knees up, you lay on the floor, you open up like this. I love it for a lot of reasons. I have people take really deep breaths while they do it because moving that diaphragm can be very helpful. Diaphragm and pelvic floor like to do the same thing. But to the question is also the answer is yes, we need to get their pressure to be managed better. And how do we do that? Like, depends on what that person is going through, but everybody who had a pregnancy lost some mid-back rotation and lost some ability to take big, deep breaths. And so we can work on getting that back, or we can work on trying to keep that as long as we can. What's really interesting is a lot of fitness providers are like, you can't rotate during pregnancy. And so then I'm stuck up against, well, my favorite influencer told me to stop rotating. And I'm not sure where that overwhelming let's stop rotating came from. But most people can rotate safely during pregnancy and should. We do see, because when we add length to the abdominal wall, muscles work on length, tension, relationships. We do see them not working quite as well as they used to. You might see an increase in, if someone was doing like a row with rotation, for instance, you might see people bothering their bodies a little bit more during pregnancy. I don't actually see that, but that's my only like theory as to where we've gotten so dismissive of rotation and why it's moved up so high on my list, is because it definitely goes away. It like takes the pressure away from like, what exactly should my abdominal wall do? What exactly should my pelvic floor do? When most people, if I'm like, hey, contract your pelvic floor, relax your pelvic floor, they have no idea. They are very unsure whether they did it or didn't. So for general people, I'm very rarely saying contract or relax or lengthen your pelvic floor. And I'm saying, let's get that a different way. Let's get length out of the diaphragm, which will probably get some length or at least some relaxation out of the pelvic floor. Let's get a bigger inhale. Let's get a better exhale, which will turn on abdominal wall usually pretty nicely. So that tends to be one of my go-tos. And yes, if you can start to manage the pressure differently or better, it can help. Pressure also just gets like a bad rap. Pressure's great. Pressure like helps so much for so many things. And then we're like, oh, we got to like fix this intra-abdominal pressure. And I'm like, it's great. We just don't want it to all go the same way all the time. And so we can see patterns and see like yours is going here. Can we fix that or change that sometime?
Okay. Awesome. And I know there's still some questions. We're going to circle back with any remaining time we have at the end here. Thank you so much for all of these questions, and thank you for your insight. That was really helpful and informative. Like I said, I learned a lot.
Great.
We are going to move on to our third speaker. Thank you so much, Blair. All right. Our third speaker is Lindsay Vestal, located in Phoenix, Arizona. Lindsay graduated as an occupational therapist from NYU in 2011 and was destined to be in pelvic health. She followed her destiny, knowing she was going to be a double-horned unicorn. Not many knew what occupational therapy was, and add in pelvic health. Well, she knew she had to perfect her elevator speech, so people knew what she was doing. She became the proud founder of the first in-home pelvic health practice in New York City called the Functional Pelvis, run by an OT. Now she teaches OTs how to become rockstar pelvic floor therapists, aka double-horned unicorns like herself, and she created the only pelvic health certification based on over 200 core competencies from the OT practice framework. She is the host of a community on Facebook of over 8,200 practitioners and is also the host of her weekly podcast, OTs in Pelvic Health, empowering fellow occupational therapists with the path to have a successful and fulfilling career in pelvic health. Lindsay thrives on being a connector to bring people together and improve the way healthcare providers learn and help others. Her talk is titled The Body Between Us: How Pelvic Floor Dysfunction Affects Relationships, Self-Image, and Sexual Health. Hi, Lindsay.
Hey, Amanda. I am so honored to be here today. Thank you for that wonderful introduction.
You're welcome. And I've just
Dr.
given you
Powell.
control.
Awesome. Awesome. Thank you to Dr. Powell, so compassionate and evidence-based. And thank you, Dr. Blair. I was blown away with your passion and commitment. And thank you so much for everything that you shared. I am so excited to be talking today about, as we know, something that affects millions of people, but is rarely discussed openly. So I love that we're doing this today. When we think about the pelvic floor dysfunction, we often think about those physical symptoms: pain, incontinence, dysfunction. But today, I want to talk about something deeper: how pelvic floor dysfunction reaches far beyond the body and into the very core of who we are and how we connect with others. And as Amanda so kindly introduced me as someone whose private practice specializes in pre and postnatal people, and I've trained over 2,500 practitioners to also work with the pelvic floor, I want to say this talk is deeply personal. When I gave birth 12 years ago, I had a 3.5-degree tear. I was already a pelvic floor therapist, and I just gained so much compassion and so much more passion to really be able to speak on this topic and to help others. So without further ado, so how do I advance the slides? I know it says I have control, but
So you should just be able to click the screen.
I'm trying that and it's not going
Let's
forward.
see
Oh,
it
here we
going.
go.
It's going. I think it has maybe a little delay.
Little delay. Okay, perfect. Perfect. All right, we'll go with this. So pelvic floor dysfunction doesn't just impact daily function. It really impacts our sense of self. And for so many people, these symptoms get really wrapped up in shame, anxiety, and isolation. They really begin to withdraw from activities that really mattered to them, from relationships that once brought them joy to really just the perfunctory things that we need to do in order to get through our day. Amanda, it's not responding to me. Do you mind if you can just kind of click through for me, and then that way I can...
Sorry about that.
No, it's no worries at all. We can just bring up the entire slide. That way we don't have to worry about tying it in. Okay, perfect. And so here's something crucial that I feel like we really need to be talking about more and more, which is that pelvic floor dysfunction often intersects with trauma histories, and this really creates so many layers of complexity that require our compassionate attention. All right, let's go to the next slide. Let's start by exploring the psychosocial impacts, right? So when someone experiences a pelvic floor dysfunction, so often in my clinic, they're describing really profound changes in how they see themselves and their body. Imagine waking up one day and feeling like your body has betrayed you, right? That you can no longer trust the vessel that really you use to walk through this world. So many people describe feelings of disempowerment or loss of control. Simple, everyday activities, going to the grocery store, attending social events, or really, quite frankly, as basic as leaving the house, become a huge source of anxiety. They are thinking to themselves, what if I have an accident, right? What if pain flares up? What if people notice that there's something the matter with me? And so what happens when we have these really basic questions about ourselves is we then tend to avoid any sort of social or intimate settings, which only deepens the isolation. So again, increased anxiety, depression, hypervigilance, leading to the nervous system, which is something I am so passionate about. I actually have the only certification out there that ties together both the pelvic floor and the nervous system. I really think that that actually should be pelvic floor 101, because when the nervous system is constantly alert, scanning for threats, monitoring every sensation, which are all things I can relate to when I went through my own birth injury 12 years ago, that state of chronic stress just takes on such an enormous toll on our mental health and well-being. Okay, next slide, please. I want to talk about sexual identity now, because even though we don't talk about birth injuries very often or pelvic floor dysfunction, I think sexual identity and sexual health is even more taboo. And it runs so deep. So many people describe a profound disconnect from their sexual self, almost as if that part of them has gone into hiding. When the pelvic region becomes, quite frankly, associated with pain or unpredictability, it is so natural for the mind to create distance from those sensations and experiences. Fear or pain associated with intimacy really becomes a protective mechanism. And I loved describing that to my clients because their body is really trying to keep them safe. And it's just such a beautiful reframe. The thing is, this can really rob people of connection and of pleasure and seeing themselves outside of the identity of being a parent. And we also see loss of desire and arousal, not because people don't want intimacy or they don't love their partner, but because their nervous system has learned to shut down in anticipation of discomfort. To me, one of the most heartbreaking things are those internalized messages of dysfunction or brokenness that people carry. They begin to see themselves through the lens of those symptoms, forgetting the wholeness that existed beyond their physical challenges. Okay, next slide, please. These individual impacts really inevitably ripple into personal relationships, and physical intimacy becomes reduced or completely avoided. And partners that once were so close have a huge distance from them. And it's not just about the act of sex itself, it's even non sexual physical affection, like hugging or cuddling, that becomes complicated because someone is experiencing pelvic pain or dysfunction. The other thing that I see that's actually a huge part of this is those communication breakdowns, because these topics feel really vulnerable and shameful, or maybe even too complex to discuss. So we see avoidance or misinterpretation of a partner's actions, right? Like a gentle touch might be perceived as pressure, or a partner's patience might be misread as disinterest. So both partners are going through such a myriad of feelings, everything from guilt, resentment, to rejection. And the person with symptoms might feel guilty for quote unquote depriving their partner, while the partner might feel rejected or helpless. So here is a crucial point. Partners may not know how to talk about these issues, and so therefore these relationships, silence often replaces connection, and that silence can really be deafening. Okay, next slide, please. Okay, so this leads to incredible shifts in relationship dynamics, right? We can see role strain where partners become more like caregivers rather than equal partners in an intimate relationship. This can fundamentally change the dynamic of how couples relate to each other. Fear of initiating, which is actually a very huge problem, even when folks haven't gone through pelvic floor dysfunction, but it's just exacerbated once they have. So fear of initiating intimacy becomes common on both sides, right? One partner afraid of causing the pain, the other afraid of experiencing it. So emotional needs really become mismatched emotional needs, with one person needing that space and understanding, while the other is looking for reassurance and connection. And what happens in these situations is decreased emotional closeness, really at a time when both partners want nothing more than to be close. Couples describe this as feeling like roommates rather than romantic partners, people who just have had a child, brought a child into the world. And they're often talking about losing that emotional and physical intimacy that once defined their relationship. Next slide, please. So, how do we approach these complex challenges? I'm a big proponent of trauma-informed strategies that I think really recognizes the deep interconnection between the physical symptoms and the emotional well-being. First up, and very important, is prioritizing safety, choice, and empowerment, right? These are concepts that many times once we've gone through pelvic floor dysfunction, we don't feel like we have any of those things. So this means creating environments, right, where we feel safe to share our experiences without judgment, where we have choices about our care, and where we feel empowered rather than helpless. So using inclusive, affirming language that doesn't pathologize or shame, and instead of talking about dysfunction or failure, let's reframe that as the body's protective responses and, quite frankly, beautiful adaptive strategies. I also love to normalize conversations around intimacy. These discussions should be as normal as talking about any other aspect of health and well-being. I think even more so. We validate people's experiences and hold space for their emotions without rushing to solutions. So, remember, and this is a special note to all of my professionals joining this incredible summit, but also if you're just somebody who has a fellow person who has had a birth injury, remember that you are not someone to be fixed. And remember, to my medical professionals, we're not fixing people. We're facilitating reconnection with their body, with their partners, and with themselves. And when you do this, safety and consent are everything. So I am a pelvic floor therapist. I can do internal exams. That is part of our training. However, in my own training and in the occupational therapy lens, one of the things I really love to promote is the fact that the internal exam is actually not the gold standard because of safety and consent. I actually have taught folks to have a menu of options, everything from their clothes fully on to do a pelvic floor assessment, which really teaches the value of interoception or understanding your own body, all the way to the internal exam. Because once again, if we know that a trauma-informed approach at the end of the day is going to be that thing that helps someone feel safe, guess what? Now, all of our incredible home exercise programs, all of our incredible breathing strategies, all of our amazing manual skills can actually be effective because the client's nervous system is in a state that they can actually accept that change. Okay, let's go to the next slide. Okay, in this slide, I really want to speak directly to anyone in this amazing conference who might be experiencing these challenges, whether it's personal or professional. These are some truths that I really want you to hold on to. You deserve to feel safe, respected, and in control of your own body and your healing process. Your comfort and readiness matter more than any timeline or checklist that others may have in mind. Talking about intimacy and pain is normal and actually really valid. Even though these conversations are really difficult, it's part of reclaiming your voice and your agency. You're not broken. Your body is responding in the best way it knows how. Actually, often trying to protect you from further pain. These responses make sense, even though they're inconvenient and distressing. Healing includes your emotions, your voice, and your choices. It's not just about fixing physical symptoms, it's about honoring your whole self in the process. So, whether you're a healthcare provider, working with people experiencing these symptoms, or someone living with pelvic floor dysfunction yourself, it's important to know that healing is not just physical. It starts with safety, trust, and having your own voice heard and valued. Next slide, please. All right. Let's talk a little bit about what healing could look like. And honestly, it's a lot more gentle and gradual than you might expect. So healing might look like learning to reconnect with your body gently. No force, no urgency. It could look like exploring ways to feel more at home in your own skin, rediscovering what feels good and safe in your new body. It includes using things like breath and movement and grounding techniques to help the nervous system feel calmer and safer. And these aren't just wellness buzzwords. They're literally practical evidence-based tools for shifting out of hypervigilance and more into a regulated state. That's going to make you a better partner. That's going to make you a better parent. And that's going to give you a better sense of connection to yourself. Building trust in relationships through open, honest conversation, communication is, to me, an uncompromised, crucial part of the process. This means having conversations that, yes, do feel awkward at first, but ultimately, I call it clearing the decks. It creates deeper intimacy and understanding, and often a more profound connection than you ever had before because of what you went through together as a couple. Getting support, recognizing that you don't have to navigate this alone. There is no shame in asking for help through therapists, healthcare providers, support groups, trusted friends, anyone that you want to turn to. And here's something important to remember. Healing doesn't come from doing more. Often it comes from listening to your body, honoring your needs, going at your own pace rather than pushing through or forcing progress. Next slide, please. So I want to leave you with this thought. You are not a problem to be fixed. You are a person to be supported, seen, and heard as you find your way back to yourself. This work, whether you're providing care or seeking it, or maybe both, like I was, is about recognizing really the profound humanity in every person's experience. Pelvic floor dysfunction touches some of our most vulnerable, intimate aspects of what it is to be a human. It affects our sexuality, our relationships, and our deep sense of safety in our own bodies. When we approach these challenges with compassion, patience, and trauma-informed care, we really create a genuine space for healing, not just for symptoms, but for the whole person. We restore not just function, but dignity, agency, and the capacity for meaningful connection. Thank you so much for being here today and for having these challenging conversations with us all. It was so incredible to be here.
Thank you so much. That was awesome. And a very needed topic, I think, for us to discuss how these tears impact our own relationship with ourselves and also the relationships with those closest to us. And I saw a lot of questions coming in during the chat. Please make sure you keep sending them in. Let me open that up here. One of the first questions that I would love to tackle is, oops, I think you're still controlling my screen, Lindsay.
Oh, sorry.
That's okay. Give me one moment to stop that. There we go. All right. One of the questions that we have here is resources for partners. And I know Solace has some. We have a web page that has some tips for partners in communication. Postpartum Support International has peer mentor and support groups for partners as well. But what do you have, Lindsay? What do you think?
I'm sorry, can you ask me that one more time? My screen just like froze up for a second and I
Oops.
lost audio.
Oh, I'm so sorry. Yeah, no problem. I was asking about resources for partners that you know of. I listed a couple that we have at Solace and Postpartum Support International, but do you have advice on where to find more resources for partners to educate them on kind of what it's like?
That's such a great question. You know, I feel like there's such a deficit for resources. So honestly, I don't have anything else to suggest other than what you said. Katrina in the chat is offering what she calls a tactical recommendation that really worked for her. And this is really specifically about reclaiming yourself and your sexuality and your intimacy. She is recommending something called Dipsia, which is an audio book. It's actually a catalog of all different romantic stories. And I love the part where she says, getting my brain to remember the joys and experiences of intimacy before my body was ready was a great ramp to getting to the physical side. And I think there is nothing more, you know, let's call it sexy than communication. So I think being able to talk first, be able to, I remember one of the hardest things for me was turning to my husband and telling him the dysfunction I was going through, even though he knew that I had my own private practice supporting women in the same situation. Number one is being able to communicate what's going on. And then things beyond that initial conversation that can get you thinking again about things outside of your sense of your roles. Here I am caring for this new baby. Here I am trying to identify new role changes that I have being a parent. Last thing we're thinking about, and then most of being touched out, is what it feels like to be a sexual being. So the recommendation that Katrina recommended is great to remember a part of ourself that maybe can be challenging to reconnect to so that we can start to feel those feelings again and make space for a part of our lives that can really complete us.
Great. Great. Yeah, like physical, mental, they're all connected as we've heard multiple times today. Another question that we got, and let me open that up one more time. Oh, maybe those are for some of the other panelists. Any other questions for Lindsay about
Actually, I do have another
intimacy?
resource to share.
Please go ahead.
I actually have started, so I own the functional pelvis, I train OTs. But another resource that I have is something that my husband and I have started on the side, just because through my own 3.5 degree tear and dysfunction that I experienced, we're really passionate about helping couples. So you can find us actually on Instagram, and it's Lindsay and Doug. Really passionate about sharing evidence-based, but also just really practical day in and day out tips to be able to rekindle the communication and the connection. So I wasn't planning on bringing that up, but as we were mentioning Dipsea, I was like, wait a second, this is a passion project and side project of mine that if any it resonates with anyone, I'd love for you to check us out.
Great. Thank you. During your talk, you were chatting a little bit about, I heard you say hypervigilance and some things that I think a lot of postpartum women experience, even without severe tears that are traumatizing. You mentioned breath work and grounding. What is that? What is grounding?
Yeah, so I mean, grounding can be defined so many ways. One of the things I usually like to say to my clients are, what are things that make you feel like yourself again? And there's things that are simpler than ever. I'm not talking about 2 hour long bubble baths. I'm not talking about some 20-step program. Simple things. For instance, I love to start my mornings off. I'm in Phoenix, so it is like 72 degrees here today. So for anyone bundled in snow, this may not resonate with you, but I love to start my morning off every day with coffee, sitting outside. I have my shoes off. I'm feeling the ground beneath my feet. I'm taking in the fresh air, the sun on my face. I give this as an example because it is often the most simple rituals that provide groundedness. So grounding is really something that makes you feel like yourself again. It could be a simple stretch. Right before I gave this talk, I was on the ground doing some thread the needle for the same reasons that Dr. Blair talked about, really getting your torso to open up and distribute pressure, grounds me before a talk like this. So I would encourage anyone to kind of take out a pen and paper and ask themselves, when do they feel most like themselves? And please make it the most simplest answer, right? So it's not when you're on vacation. It's not when you're, at a spa. It's really the things that are accessible to you right now, like going out in your backyard and having a cup of coffee. It could be something that you've relied on most of your life that really brought you home, or it could be something new that when you give yourself a chance to really just kind of answer that question and sit with a little bit of the awkward silence because you're not sure exactly how to answer it yet. And maybe you'll be inspired and prompted by a new activity, morning walks through your neighborhood, you name it, painting your nails, whatever the case may be, but something simple to really give yourself a chance to remember that you matter. When you start to prioritize yourself, it really is that, such a like a overstated thing, the whole oxygen mask thing, put your oxygen mask on first. But honestly, it is, there's so much wisdom in that. I find that once I have those grounding moments, I am a better partner. I am a better employer. I am a better parent. And so grounding at its most simplest is just what brings you back to a sense of calmness and ease that helps you continue your day.
That's great. It is very cold up where I am, so that sounds like a dream way to start the morning.
We'll talk in July, Amanda, and then I'll be wishing this with you.
Sure. We did get a question. How can we find a therapist that we'll talk about this? How do we know we found the right practitioner? Should we be looking for an occupational therapist or I don't often hear that OTs are where I should head for, postpartum trauma, to kind of navigate through it. But it sounds like maybe that is exactly where we should be looking. Can you talk about that?
Yeah. So, I'm not so sure it's so much about the credential. If you're a physical or an
Mhm.
occupational therapist, I would go to Dr. Blair in a heartbeat. I loved her emphasis on education, autonomy. So, I will do a quick plug for OTs and say, that we do have a background in mental health. So we actually are mental health providers as well as physical providers. And so for me, I actually sought out occupational therapy. I sought out being a double-horned unicorn because I really wanted to be able to address the vulnerabilities, the sense of self, all the identity shifts when I was talking about my pelvic floor issues. And please know this was coming up on almost 18 years ago now. I do believe that now nervous system regulation and things like this are much more common part of the training, but that wasn't always the case. And so I would say that the best thing that someone can do who's trying to find the right therapist, and this goes back to something that Dr. Powell said, which is interview. don't be afraid to seek out a second and third person. And if I tell my client, like, call up a provider, ask. Number one, Dr. Blair told us about Kegeling, how that isn't the end all be all. You might find some old providers who actually think it is. So have a couple questions on hand. If you know that Kegels aren't the end all be all, ask to speak to the therapist. What's their view on Kegels? Ask if they're trauma informed and what that means to them. Ask, where their passions lie. Is it someone that has experience with working with birth injuries? These things matter because this is giving you agency and it's assuring you that you're in the right hands. So please know that it's not about finding any provider. It's about finding a provider that you feel comfortable with. And I honestly think that if the provider won't get on a call with you, that could be a red flag. Not always, but I do think that this is the type of thing and the type of work. We're not cutting hair. This is not a perfunctory thing. This is something that we have to deeply connect with you about. So I do think they should make time to call and chat with you. The second thing is, let's say that doesn't happen and there's just one provider in your area and maybe you had to travel to them. My feeling is that if there isn't a connection after meeting them, don't barrel through it. You can find telehealth practitioners. That's becoming more and more common these days. But continue to shop around until you find someone that you're seen and heard, because a provider that matches you is the most important thing. And that's not something, Amanda, that maybe you would need a different provider than I would. So there's not a classic example, but there should be a vibe. There should be a connection where you feel seen and heard.
That's great. I actually didn't know that you had occupational therapists had so much background in mental health. So I think that's fantastic that this gives another whole pool of resources for people seeking therapy for their mental health and their self-image and their just their relationships with themselves and maybe their partners that maybe we didn't know about before. That's awesome. Thank you so much.
Physical therapists are probably a lot easier to find. I personally have trained over 2,500 OTs. So we're definitely, a little bit less common, but I think that's just the case in general, even if it's not pelvic floor therapy. But absolutely, OTs,
Yeah.
PTs alike, yes.
Yeah, and I'm even thinking of therapists in the sense of like cognitive behavioral therapists that you might
Totally.
seek for just mental health. So this is great that we have, obviously we have pelvic floor physical therapy for our physical symptoms and they're going to be able to give us a lot of knowledge, but even just it can be hard to find a therapist, a CBT, or somebody to help us with EMDR. So having a whole nother world of practitioners to call is great.
I love that. That's perfect.
Awesome. Thank you. All right. I know there's still some questions in the chat. We'll loop back to whatever we have time for after our final speaker. Last but certainly not least, we have Alexia Foster. Alexia is an LPN and a mother who suffered OASI during childbirth. Alexia not only faced the challenges of physical recovery as a result of her OASI and complications, but also struggled with mental health during this incredibly vulnerable time in her life. Alexia, thank you in advance so much for sharing your story with us and shedding light on this very stigmatized topic. I turn it over to you.
Thank you. Can you guys see me?
Yes, you're all set.
Okay, perfect. All right. Hello, my name is Alexia Coster, and I have a 19-month-old baby boy named Carter. I am 25 years old, currently staying home with my son. However, I have been an EMT for 6 years and a nurse for 2 years. My purpose in sharing my story today is to bring more awareness to the effects that traumatic deliveries have on postpartum women and to show all mothers that you are not alone. I do want to start this off by saying thank you to Dr. Powell. I am a former patient of his. I appreciate everything that you have done for me, and thank you to the SOLACE Foundation for allowing me to share my story. On Monday, June 24th, 2024, after an elective induction and 16-hour labor, I gave birth to a beautiful baby boy. He was 7 pounds, 11 ounces, 21 inches long. By my side was my wonderful husband and my sweet friend from nursing school, who happened to be an L&D nurse at the hospital that we both worked at. My goal in labor was simple: don't die and leave with the same amount of holes that I came in with. Well, you can't have it all, they say. I was completely unaware that anything had gone wrong in my delivery until after my son was born. My OBGYN was stitching me up when I said, "Hey girlfriend, you've been down there a long time. Did I tear?" Mm-hmm, she replied. Is it a fourth-degree tear? She nodded her head. Just a week prior, I had expressed to her that a fourth-degree tear was one of my biggest fears. She assured me that fourth-degree tears are rare and it probably won't happen. As soon as I was informed of my condition, the back of my head hit the pillow and the tears started flowing immediately. That excitement and joy of childbirth that we are always told about was ripped away from me with a simple head nod. What have I done? I kept thinking. My husband is standing at the baby warmer, staring in awe at our perfect little boy. They laid my son on my chest and I didn't feel anything. I had been told for 9 months that meeting your baby is a moment you'll never forget, but sometimes I wish I could. I couldn't bond with him because I was too focused on what my future recovery would look like, a regret that I carry to this day. I warned the new L&D nurse that I had POTS, a disorder of the autonomic nervous system that causes increased heart rate and dizziness upon standing. I earned that diagnosis when I became pregnant. Due to the loss of fluid during labor, I passed out on the toilet and gave my poor new grad nurse a heart attack. Everyone talks about your first postpartum meal. Well, mine was mini muffins and apple juice on the bathroom floor. They were the best mini muffins I ever had. After a few bags of normal saline, I was sent to the postpartum floor. I remember my tech coming in to take my vitals, and I thought, wow, she is so pretty. And I tore my freaking butthole. I really hope she doesn't think less of me. The pain was unbearable. I felt like I had been punched, sliced, and diced, and I couldn't stand without assistance. My days in the hospital were filled with my loving parents, wonderful husband, and sweet baby. At night, however, the dreaded thought came to my mind, how the heck am I going to poop? 3 days go by, and I hadn't had my first postpartum bowel movement, despite the Colace and Miralax that was prescribed and taken. I had expressed my concerns to both my day and night shift nurses and techs, with most of their replies being, don't worry, you'll have one, or we only require gas for discharge. I remember asking if that was the same protocol for a fourth-degree tear, and every nurse replied with, I'm not sure, I've never taken care of one before. The only thing that was going through my mind was, then find out how to take care of one. Thursday rolls around and I was discharged. I expressed my concerns about a fistula or wound dehiscence with the OBGYN, who assured me that that was a rare situation and that, again, probably will not happen to me. Due to my history of anxiety, ADHD, and depression, I was sent home with Wellbutrin while waiting to get back on my ADHD medication. Sunday, June 30th, my son's original due date, and what could only be described as the crappiest day of my life. Shortly after my parents left and my in-laws arrived, I had my first postpartum bowel movement. It was painful, of course, but not as bad as I had anticipated. Throughout the day, the pain became unbearable. I took a mirror to assess my stitches, and lo and behold, I had complete separation of my wound. I went straight to the ER and explained my situation, where my chief complaint was labeled episiotomy came undone. Mind you, I never even had an episiotomy. I remember telling the triage nurse that, sorry, that was my cat. I remember telling the triage nurse that my fourth-degree tear repair had came undone and I was completely incontinent, reminding them that I was an infection risk. While all of this is happening, my in-laws stayed at home with my son, who was not even a week old. I sit in the waiting room for 3 hours, feeling ashamed, disgusted, and scared. Once I finally get into a room, I dump my entire birth story onto my nurse. I explained my situation, and she stated, I highly doubt all of your stitches came undone, but I will have the doctor take a look. I told her I am literally one hole right now, to which she proceeds to tell me that she has had children before and what I'm feeling is normal. Normal on what planet? By around 3 a.m., I was assessed by the ER doctor. I begged for pain medication prior to the assessment, as I hadn't had any all day. I told the ER doctor that I literally ripped apart. During the assessment, I see the nurse's eyes widen. My fear is confirmed, and it was an I told you so moment that I really could have lived without. The staff didn't say much, just that they will consult with OB. 7 a.m., the OBGYN who delivered my son came in to do a second assessment. She stated that I had to have surgery immediately. One of my biggest fears was general anesthesia, so I asked if I could be conscious during the procedure. She told me, you aren't going to want to be awake for this. She was very calming and reassuring, but my fears were very real. I had a panic attack in the pre-op room. I was convinced that I was going to die. I had no idea what was happening to me or what was going to happen. I told the anesthesiologist that all I wanted was to be home with my baby. I was so inconsolable and very convinced that I was never going to wake up. I was given Versed and put under for my procedure. When I woke up, my gown was soaked. I asked why I was all wet, and my husband told me that he had been pumping my milk for me because he knew how much pain I was in and didn't want me to have to deal with the pain of engorgement. He described the scene as similar to the Vegas fountain. My mother-in-law FaceTimed me so I could see my son, whose head was still trying to take shape after being stuck for so long. Poor guy wore hats for a really long time. The next morning, my OBGYN discharged me with a more aggressive bowel regimen, Miralax twice a day, Colace every time I took a pain pill. I followed her instructions and had my first bowel movement at the hospital. 12 hours after discharge, I realized something was very wrong. My wound had begun to break down once again. My bowel movements were now coming through my perineum, and I went back to the ER. As I am waiting in the ER waiting room, I am inconsolable. Every time I go to the bathroom, more stitches are on the toilet paper. My OB saw me much quicker this time, within about 4 hours. She had assessed my stitches and stated that they were intact and that I may just be feeling the effects of the bowel regimen. I was sent up to postpartum for observation overnight, and I was given Ativan for anxiety. I kept explaining to the nurses what was happening and that I felt like nobody was listening to me. The OBGYN who had initially discharged me after labor was back again. He was coming to discharge me once again. I told him something was wrong. He said, "I know you think your bowel movements are coming from your perineum, but the doctor assessed you in the ER and said your stitches were intact." I said, "I'm telling you that there is something wrong." He asked me if I wanted him to assess my surgical site, to which I stated yes. He returns with the speculum and performs his assessment of my stitches. When he finishes, he states, "I see what you mean. I don't see anything externally, but I believe there is some wound breakdown in your internal stitches. I'm going to refer you to urogynecology at UAB. I think you're going to need another surgery." I was distraught. What do you mean another surgery? Is that even possible? My anxiety was through the roof and my confidence was below the basement. I couldn't even look my husband in the eye. I cried to the nurse and said, "I just want to be able to have another baby," to which she replied, "You can always have a C-section. Worry about the baby you have now before thinking of any more." I left the hospital with tears, dermaplast, and 2 more prescriptions for anxiety medication. I was now on 3 psychiatric medications, none of which worked. I was referred to Dr. Thomas Clark Powell, who called me the very next morning. He assured me that they will take good care of me, which gave me the first shred of hope I had since my delivery. 5 days later, I saw him for an in-person appointment. He broke the news of a 3rd surgery, this one occurring 6 weeks after healing. He also wrote down the website for the SOLACE Foundation and encouraged me to look into it for support. I did that night, and for the first time, I didn't feel alone. Seeing the recovery stories published on the website gave me some hope and terrified me at the same time. After hearing the outcome of my appointment with UAB, my mother-in-law, Danelle, decided to stay in Alabama with us until I could fully recover. She also experienced a 4th-degree tear with her first child. For 6 weeks, she cared for my son, assessed my wound, cooked for me, cleaned my home, and provided the necessary medical supplies for my recovery. Tux Pads, if you're hearing this, please sponsor us. All while working from home. She was my rock. I was able to discuss things with her that I was too embarrassed to tell my husband, and she's seen more of me than she ever wanted to. During those 6 weeks, I remained in bed, curtains closed in total darkness. I obsessed over the feelings and opinions I had about myself. Disgusting, broken, and unworthy. I felt as though I was shedding my femininity as quickly as I was shedding my stitches. How could my body have failed me not once, but twice? Also, why am I having a panic attack and crying every time I go to the bathroom? Not only did I feel like a failure as a woman, but I felt like a failure as a mother as well. All the things that a mother should be able to do, I wasn't. I was not the first to rock my son in his rocking chair or bathe him. The infant carrier that I had put on my registry was fitted to my husband's chest instead of mine. I didn't eat. All I did was sleep. I made sure that I stayed on top of my pain medication, not only because I was truly in pain, and I really was, but also because sleeping was better than being awake. When I was awake, I was obsessively Googling statistics. I'm sorry, it's my cat again. And looking for success repair stories. Bonding with my son was the last thing on my mind. I knew he was well taken care of. I closed myself off to everyone. I stopped talking to my parents, my friends, and my own husband. I couldn't bear to look at myself in the mirror. Shameful, ugly, disgusting, and deformed. Those were the only feelings I had. Everything else felt numb. One day, my mother-in-law broke down. She said, "Honey, while I'm happy to be here, I am so sorry that you have been robbed of this experience." She opened the blinds and put my son on my chest and said, "You need to bond with your baby." How could I thought. Did he even know I was his mom? I felt as though she was a much better mother than I, and I did not deserve to be his mom. How could God give me such a perfect human being when my body couldn't even do what it was created to do? I kept wondering, why me? I blamed God initially, asking why he would put me through so much physical and mental pain. There had to be a reason, right? There is no way this is happening just because. My 6 weeks postpartum appointment quickly approached, and it was 2 weeks before my repair at UAB. In the waiting room, I heard the same song that played every time I had an appointment, "God Be the Glory" by We Are the Messengers. The lyrics that stuck out to me the most were, "I will trade strength for my weakness, pain for my healing. Let this be my story, to God be the glory." This would then become my fight song, a reminder that God is with me and he will make a way for me in the darkness. This song also inspired me to continuously share my story, like basically to anyone who had ears. My OB appointment ended with a referral to a therapist who specialized in birth trauma. I visit her weekly via Zoom. She was very kind, but my depression only worsened. I continued to play my fight song in the shower as I cried, trying to remind myself that God had a purpose for my pain. The day of my repair goes smoothly. My anxiety earned me another pre-op dose of Versed. The room was filled with residents, and the last thing I remember saying was, "Enjoy the show," as I lay spread eagle on the operating table. I woke up a few hours later, best nap of my life, and I saw my parents sitting next to me, completely distraught over what has occurred over the past few weeks. The next morning, I'm discharged with a Foley catheter due to urine retention, to which my husband learned to empty for me. It was an agonizing, painful 3-hour drive home, but I was excited that I got to see my baby for the first time in 2 days. A week after my surgery, my son stops breathing. He turns purple, as my mother-in-law quickly calls 911. When the police officer walked into my home with an AED, I was sent straight back to a call that I had been on when I was 20, where my youngest patient passed away at only 4 months old. The powerlessness and panic that I felt was unreal, and I was instantly transported back to that day in August of 2020. We go to the ER, where my son is discharged with GERD and a follow-up for a swallow study. This becomes an almost daily occurrence after feeding, and we are given a plan of care to manage his GERD. I'm unable to sleep. The fear of losing my baby has now overcome any fear of a failing repair. We continue to bring him to the ER after almost every blue spell. He's continuously vomiting and not gaining much weight. I feel dismissed once again by almost every medical professional we had seen. I kept thinking I must be going crazy. 4 weeks post-surgery, the Army moves us across the country to Washington State. I'm terrified. Now I have to pack up my entire life and find a whole new provider for myself and my son. My in-laws help us move, my father-in-law driving with my husband, and my mother-in-law flying with myself, the baby, and our cat. During the move, I overexerted myself and popped some superficial stitches. I stepped off the plane and immediately went to the ER on base. I explained my situation to the ER nurse, who quickly ensured my pain was managed. The ER doctor performed a physical assessment and states, "It has been so surgerized that I'm not sure what it's supposed to look like, so I'm going to consult with OBGYN. You have got to be kidding me. Not sure what it's supposed to look like? There it goes. The last shred of self-respect I had out the window. My life is over. Intimacy is over. I will never feel like a woman again. These thoughts raced in my brain for 3 hours until the OB team eagerly enters my room. The residents express their excitement to assess my wound, as an occurrence such as this is very rare. It was a bitter reminder that what may be an interesting day at work for me was someone else's worst nightmare. I was admitted to the med-surg floor for an MRI with oral contrast. I was wheeled down to radiology when only then was I informed that it would be rectal contrast, not an oral one. The radiology techs were explaining to the resident radiologist how to perform the scan. I stated, "Really? Right in front of me and my brand new butthole?" I begged for pain management and didn't receive any until after the scan. I was pumped with so much pain medication that I was unsure if I was even able to consent to the procedure, but it was performed anyway. Dr. Powell calls me while I'm in the hospital and continues to do so about once or twice a month for 5 months, ensuring that my physical and mental health were being taken care of. He saved my life in more ways than he realized. The next morning, I had returned home. I am discharged and referred to an OBGYN for a follow-up to assess my healing. I had barely been in the state for 48 hours. A few days later, my 4-year-old cat suddenly passes away overnight. When we woke up, it was too late. The scream I let out was ear-piercing. I told myself, my son is next. I'm going to wake up and find him dead. This thought didn't leave my mind for months. I didn't sleep, constantly checking on my son to make sure I didn't find him dead too. My husband returned to work from paternity leave, and I'm finally on my own to care for my son. I expressed at my OB appointment that my anxiety and depression is crippling, and while I'm not suicidal, I fear I may be if I do not receive help. He writes me a script for Lexapro, a medication that I had already been on, and gave me a referral to mental health. I called as soon as I got in the car, and every day for 6 weeks, but nobody picked up the phone. I continued to call my OB with concerns for my mental health, to which he stated he has done all he could do for me, and someone will eventually pick up the phone if I keep calling. I'm not sleeping. I'm obsessively checking my son's outlet to make sure he doesn't stop breathing. Concerns for my repair are still in the back of my mind, but my son's safety is at the forefront. I didn't leave my house. What if I get into an accident? What if somebody follows me home? What if somebody hits my baby in the parking lot? What if I poop myself? I could picture these scenarios in my mind as if they were actually happening. My husband has to leave for a few days, and all I could think is, what if someone breaks into my house? I stayed up late every night while he was away, peering through windows, sleeping next to a firearm, and waking throughout the night not only to assess my son's breathing, but check again to make sure all the doors were locked. I fully believed that someone was stalking us. I mean, it would just be my luck, right? My husband returns home, but my racing thoughts still occur. What if your son stops breathing? What if your repair fails? What if your husband gets into an accident? You are so disgusting. Your body was literally built for childbirth, and yet you failed. Seeing my friends have children with minimal to no tearing just made me feel like more of a failure. I even once had a panic attack in Seattle because I fully convinced myself that someone was going to take my child's stroller and throw him into the harbor, causing him to drown. I spent the entire afternoon planning my son's rescue. Thoughts of harming my child would also occur randomly, a detail that I only ever shared to my psychiatrist. It's not that I wanted to hurt him, it's that I felt I was so mentally unstable that I was afraid of slipping into psychosis and hurting him. The day my son turns 4 months old was the day that I decided I had enough. Somebody was going to listen to me. My husband went to the store when my son began crying. Crying would trigger his GERD, which would trigger a blue spell. I panicked, thinking he was going to stop breathing. I thought, I'm going to lose my son at 4 months old, just like I lost my 4-month-old patient. I couldn't get my son to calm down, nor could I calm myself. I placed him in his pack and play, and I go to the bedroom and hit the wall with my hand and begged my son to stop crying. At that point, I knew it was time to take my mental health into my own hands. I called my husband and begged him to come take Carter from me, and I drive myself to the emergency department. When I arrive in the ER, I tell the staff that I wanted to die. Did I actually want to kill myself? Not necessarily, but I wanted a car to hit me. Or I wanted to accidentally fall down a flight of stairs. Passive suicidal thoughts, they called it. I'm quickly changed into paper scrubs and my belongings are taken from me. I didn't care. I just didn't want to be alive. I prayed that I would somehow stop breathing, that I'd have a POTS attack with a lethal arrhythmia as the end result. I was admitted to the psychiatric unit that very night. The nurse that had been assigned to me during my stay on the mental health floor didn't have children and could not relate to me in the slightest. I felt like I probably sounded absolutely insane, which embarrassed me even more. My mother-in-law was on a plane the very next morning to come help my husband with our son. I remained hospitalized for 3 days. During this time, my husband visited and printed a picture of Carter to remind me why I was still here. Within 24 hours of my discharge, I was sitting in a therapist's office. Finally, it took me wanting to lose my life in order to be taken seriously. I sat across the room from a tall, middle-aged man, telling him every detail of the last 4 months, thinking there's no way in hell a man in his 60s is going to help me. If my nurse couldn't relate, this guy really can't. But he did help, more than any therapist I had ever seen. Once I explained my situation, he squeezed me into his already jam-packed schedule. I saw him weekly for almost a year. We worked through my birth trauma with EMDR therapy and talk therapy. We even celebrated when I finally got off Miralax. He watched my son grow as a human just as he witnessed me grow as a mother. Many times I wanted to give up. I had even expressed to my psychiatrist that I wanted to terminate treatment, but I had to make a choice every day when I woke up. Did I want to be a victim or did I want to be a survivor? It was a fight every single day. I had to fight the fear of having an accident in public, the fear of not making it to the bathroom on time, the fear of something happening to my son, the fear of never having sex again. But I refused to let the mother that I wanted to be become unattainable. Sure, I could sit around and continue to feel sorry for myself, but sulking doesn't get you anywhere. After a year of therapy, many tears, and lots of EMDR, we both agreed that I was able to be discharged from my therapist's care. He told me if I ever needed to come back, he would fit me into his schedule immediately. I felt safe. I continue to see a psychiatrist for medication as of today, and my mental health is thriving. While I know this story highlights a lot of failures in the healthcare system, the outcome is what I want to recognize the most. I am okay, my son is okay, and I am loved. I was lucky to have had the endless support from my friends and family. I truly could not have survived this season of my life without them, especially my husband, my parents, and my in-laws. Earlier, I had mentioned that God had a purpose for my suffering, and I truly believe this is it. I had messaged Carolyn on Facebook and told her how much her foundation had helped me in the early stages of my recovery, and a few months later, she asked me to speak at this conference. As of today, I am 19 months postpartum with no long-term complications. I was discharged from pelvic floor therapy with 95% strength, and I am able to live my life normally. I look normal, I feel normal. It's almost as if I didn't have a baby. By sharing my journey, I hope that this brings more awareness of the severity that OASIs have on a postpartum mom's mental health. As someone who has worked in the healthcare system for a while, it is easy to write off a patient. I have been guilty of that myself. However, if a patient is telling you that something is wrong, you need to investigate it further. Had I not advocated for myself so much, I wouldn't be here today. I also hope that my story brings home hope to any new mother who is experiencing the early days, weeks, months of postpartum. I can promise you it will not be like this forever and things will get better. Looking back, I would do it all over again for my son. You are loved, you are important, and your feelings matter. Thank you.
Thank you, Alexia. First, I want to say thank you for sharing this story. It is very personal, but I think, and I can speak from my own experience, so many of us who have been through similar, this resonates, right? This resonates so deeply with how we've all maybe had to go through similar dark times and healing and questions. So thank you. Before we dive in, I do want to say congratulations on your graduation from therapy and physical therapy. That's awesome.
Thank you.
And we know how hard it was. And I also want to say thank you for letting Solace know about your journey because sometimes we just don't know what impact the work we do has, right? If it's just going into a void somewhere, if it's actually making a difference. So I just can't express to you how humbled and grateful we are to you for letting us know that and for being a part of your healing journey.
Thank you.
Yeah, thank you. So, folks, if you have any questions for Alexia, she is here to answer them. And I'll kick it off with one question, which is, can you tell us a little bit about your experience with EMDR, the eye movement desensitization and reprocessing, which for those of you who don't know, it's a type of therapy that helps people heal from trauma. So tell us, what was that like?
Yeah, I mean, to be honest with you, I thought my therapist was a little crazy for wanting to try it because I had been dealing with anxiety and depression my entire life. And, I'd seen countless therapists and none of it really worked. But it was kind of crazy because it only took like one session for me to reprocess the trauma of the delivery and even calls that I had been on when I had worked EMS. And I was able to kind of reshape my thinking, and it almost helped me process it and move forward from it. So it was pretty nice. And I was able to bring my son to, they put the two the little eggs in your hand that have like a one will vibrate and then the other one will vibrate, and you have to focus on the vibrations. And my son got a kick out of that, but it was really great. Like, I really do recommend it to anybody who has had a traumatic experience.
Yeah, I know at our last summit, one of the speakers talked about EMDR in general. So that is definitely a resource out there for anybody who is struggling with their mental health and any kind of traumatic experience. And another question that came in, glad that you had such an effective experience with EMDR. Throughout your multiple hospital stays, were you ever connected with a social worker?
Yes.
Yeah.
Yes, I was. I was connected with a social worker when I had went into the hospital with the suicidal ideations, and the social worker is actually the one that had recommended that I be placed in inpatient treatment. But aside from that, not really. That was kind of the only one, at least the only one I could remember. We also have to remember I was on so much pain medication for like 2.5 months that, I mean, some of it I just really don't even remember.
Right. Yeah. And it's also, I mean, even without the pain medication, we're talking about you just delivered a baby, you're in this sleep deprived state, and it's like the days just blur together, even without the addition of pain medication, kind of
Mm-hmm.
making things, yeah, totally. Um, this is a question for you, Alexia, and if Dr. Powell has insights as well, about the secondary repair after wound breakdown. So, maybe a little bit of insight as far as the timing of the secondary repair. Was the decision to wait, just because the statistics say the best outcome is a certain timeline? What does that look like?
That's a really good question. I think this goes back to the difficulty of treating everyone the same and needing to take individual people's experience and their physical exam into account. And our discussion at the time, and Alexia, you can weigh in, of course, because your voice is more important than mine in this. But the discussion that we had was a lot of it was surrounding the health of the tissue. And so there have been people who have advocated historically for much delayed repairs to let everything sort of run its course for a long period of time. The thinking on that has shifted now, and I do think there are some people who are candidates for an earlier repair very soon after a breakdown, as long as the tissue is not infected. But you really have to take it on a case by case basis, because you really want to be able to reconstruct tissue that is well vascularized, meaning has good blood supply and can be repaired without being on too much tension. And if I remember correctly, our discussion revolved a lot around the tissue just needing time to not be so inflamed
Yes.
and for it not to be under so much tension once the new repair was done.
Yes. And I think that the decision to wait 6 weeks was the perfect decision because, like I said, I mean, I'm very, very healed now. And um, I think if we would have done it earlier, I think that with how much inflammation there still was, that I would have probably just broken down again.
Yeah. And I will say that's a hard conversation to have. I think, and you can tell us, but I think that was probably hard to hear.
It was
Uh,
very hard.
that I thought that was the right thing to do. And it is a tough conversation to have sometimes, um, because you're essentially asking somebody to just let their body do what it will do for a period of time, and that's I imagine a really tough path to walk. But you clearly showed so much strength throughout this whole process, so I really appreciate you sharing.
Thank you. And I really
And
appreciate you because you were seriously, you were the only provider that actually listened to me. And I appreciate you so much for that.
So, well, I'm just fortunate to have gotten to work with you.
And on that note, actually, a question that came in, Alexia, and maybe Dr. P's part of the story. Looking back, you shared about statements that were said to you that were really harmful about what happened to you and what was normal, and you must just be, you had some medical gaslighting going on. What would have been or was, if you experienced it, the most helpful thing that a provider could have told you during this journey?
I'm going to take
Or what
notes
do you
on this
wish
part.
you have heard if you didn't hear it? What would have been the most helpful thing for you to hear from a
On
provider?
Honestly, I think that Dr. Powell did a fantastic job. He was very real with me. He would answer any question that I have. When he came in, he didn't make it seem like he was in a rush to get out. He sat and he spoke with us. He even, like I had said to you before the seminar started, he even cracked a few jokes with my husband and I. Um, and just really listening and showing concern, because it is very easy to write off a patient, especially with nurses. You're having contact with these patients every single day, and they're telling you something's wrong, and you look at their chart and you're like, no, you're fine, but you really don't know what's going on with them if you don't investigate it. um, and I think, like I said, I think Dr. Pell did a fantastic job just listening really and
Mhm.
answering honestly, but also with a little bit of sensitivity. Because
Yeah,
he told
yeah,
me
not just
too.
dismissing you.
Yeah, well, he told me too that I was going to probably need a C-section, and that he recommends that I have a C-section for the next. But the way that he had approached it, and the way that that nurse, had approached me having a C-section was very, very different. So,
Mhm.
um, I definitely appreciate his professionalism through all of it.
Yeah,
Well, I'm not
awesome.
kidding that.
We're glad he's on our team for sure. Um, Another question, Alexia, and you certainly don't have to answer any of these.
It's okay.
What if you could tell us, and then I'm also curious to hear from the provider side, were you prescribed pain medications after your delivery? Or was it extra strength Tylenol? Were you prescribed actual pain medication for your tear?
I was prescribed Norco. I think it was 5 milligrams, which I think the protocol at that hospital that they discharge you with is it's Norco 5 for an extra strength Tylenol for a vaginal delivery, and then Norco 10 for a C-section. But it just wasn't cutting it. I mean,
Mhm.
my wound was breaking down, and I had exposed muscle, and it was honestly the worst pain that I'd ever felt in my entire life. And the healing process for those 6 weeks was more painful than my initial tear, actually. And Dr. Powell had actually prescribed me Percocet because he had,
Yeah.
once he had seen what was going on, he was
Mhm.
a little shocked at my how much my pain wasn't being managed, because it was pretty bad.
Yeah.
I would like to weigh in on this a little bit because I referenced it in my talk, but
Mhm.
we didn't quite have time to get into kind of all the clinical details. But there are people out there who have created really good care bundles that include appropriate pain management, which sometimes needs to include even, slightly more substantial doses of opioid pain medicine. Um, but we have to combat that with doing our best to manage the constipating effects of those medicines. And
Mhm.
so it just can't be one thing. We can't I think some people are scared to treat pain more aggressively because of the potential for constipation and the implications that that can have for repair breakdown. But I think you just have to do both. And there have been some really innovative approaches of using topical lidocaine, scheduled higher dose ibuprofen or Tylenol, and then keeping the opioid component separate sometimes so that you still use that, but you're getting a lot more baseline non-narcotic pain control. And so all that to say, the thing you don't want to do, which I think we've referenced, is you don't want to undertreat pain. Instead, be more aggressive with the bowel regimen, be as aggressive as you can be with the non-narcotic medication, but even so, using the narcotics for what they're designed for. We know they have a lot of downsides, but some people need them, and they can be the right thing to do. And thinking of pain as the fifth vital sign, I know there are some downsides to that, but it can be really important.
Great. Yes, I'm glad you mentioned the bundles. Because somebody had asked us on our socials too a similar question, and I know that the care standards really are just they run the gamut in our country. It depends on where you're delivering and what state you're in, and how big is the hospital you're at, and are you in a rural place or not. So that's really helpful to hear. Thank you. All right, I did go ahead and send replies to those questions that we didn't get to. You can email them to us. I gave you the email, and I'll give you our contact again, and we will work on getting an answer for you over our email accounts. All right, awesome. Last few pieces before we wrap for the day. Thank you, Dr. Powell and Alexia, for answering all of those awesome questions. These are resources, and definitely take a picture of this slide if you need it. You can find these resources on our website as well. As you just heard, it's a hard thing to experience OASI, and it's certainly a hard thing to, on top of that, struggle with your mental health, as Alexia had shared with us today. And we so deeply appreciate the courage it took for you to share with us, Alexia. And I want to emphasize the importance of reaching out for help. And Alexia, throughout your story, you really did a great job advocating for yourself and not taking, no response for an answer. So these resources, some of them are just general resources like the Suicide and Crisis Lifeline. SOLACE also has some resources available for those suffering OASI. We do have free monthly support groups that are virtual. You can email Caroline to get the private link to join us. We also have peer recommended providers listed by state on our website. These providers range from OBGYNs to urogynecologists to therapists, and these are all sent in to us directly by our followers. So people have worked with this provider and they have decided that it's a great person to work with. So they've been vetted to some degree, and hopefully that makes it a little bit easier to find support if you are looking for it. Our website also has a lot of different educational resources to support healing, both for you if you have an OAC, for partners maybe who need to support the person in their life who is suffering OAC. Postpartum Support International similarly has these resources available. And there are some closed social media support groups. So if you have questions about joining any of those, you can email us at Solace and we'd be happy to get you connected. This postpartum period is a challenging and vulnerable time in our life, and is very much colored by the beautiful expectations that we put in our mind. And real stories from real people help us face the reality, right, of what it's like to go through these experiences. And that helps us break down stigma and misinformation and shed a light on these topics that are not often talked about and are often shied away from. The reason that Solace exists is exactly what Alexia shared about. And when I went through my OAC in 2020, and I know when Caroline experienced hers, Solace didn't exist yet. So we are thankful that we're here now. It is our mission to stay around for a long time and to keep supporting you all who do suffer OAC and need support and need healing. We want birth experiences to be improved with education, with awareness, and just with hope, like Alexia's story has provided us today. So looking ahead, I do want to give you a few options if you are interested in getting involved in the mission. At Solace, we rely on the generous support of our board of directors, interns, volunteers, and donations. So many ways to get involved in our mission if you want to. For women who are experiencing OASI, we do have free support groups, like I mentioned. You can also connect with us to share your story in any medium that you would like to share in, whether it's written, verbal, in an interview, or video. We do like to elevate real experiences because we believe it provides hope to other people, and we would be honored to support you in that process. For students, we do host interns each semester who are pursuing graduate degrees, like degrees in medicine, nursing, public health, even nonprofit organization leadership. Many of our student interns have used this mentorship opportunity to fulfill their degree requirements and graduate, and we have certainly benefited from their hard work immensely. All of this to say, if you want to be involved, we have a place for you. Please be sure to follow us on LinkedIn, the Solace Foundation, Instagram. We are at solaceforwomen.org, or you can email us at contact@solaceforwomen.org. And finally, we are a 501c3 registered nonprofit organization. Educational opportunities like this, the management of our free support groups, and the development of all of the resources we have are only made possible by generous donations, and those donations are tax deductible. If you feel compelled to donate and engage in this form of advocacy, we are always grateful for the support. And donating gives you access directly to our annual impact report, so you can see exactly what programming you are supporting. You can make a donation by clicking on the blue donate button, which is on our website's homepage. And finally, we want your feedback. So everybody who has attended today, we have a evaluation form. Your feedback is anonymous, and we would really appreciate it if you took a few minutes to fill that out for us. We hope to offer opportunities like this again in the future, so we like to make sure that what we're delivering is what you actually want to hear and see. So please take a minute to take the survey. Once this meeting ends, a link will pop up upon the closing of your browser. And there will be a follow-up email sent as well that will have the link. If you are seeking continuing education credits, you will have to submit the evaluation first, and then you will be provided an additional survey link where you can claim your CECs. If you are a CHES, you will need your CHES ID number, and if you're an Alabama nurse looking for AHEC credits, you will also need your nursing ID number. You can contact us for any issues or concerns at contact@solaceforwomen.org. And before we log off, I do want to extend one final huge thank you to all of our speakers, our expert panelists. Thank you, Dr. Powell and and to Lindsay for shedding light and information and providing us with facts and knowledge. And again, thank you so much, Alexia, for sharing your story and giving hope to all of those who are listening. The summit wouldn't be possible without you and all of the hard work and time that you have donated to us over the last few months. So we really appreciate you so much. I thank you so deeply. And thank you to our audience for attending today. We appreciate the time you took to come learn with us and support our mission here at Solace. That is all we have. Have a wonderful rest of your day, everybody. Take care.